To this, we are in unprecedented times, and now the challenge on the ENT surgeons is immense. We have to do a complete debridement of the necrotic tissue, and so that our curve of excellence, of reaching that excellence, becomes the shortest possible. This effort, our beloved CM, the very scientifically minded man, has urged upon us. So we thought we'll create 100 warriors, but to people are responding to his call. I think we've got more than 180 already, and more are wanting to come. So we will do this probably twice a week. And Satish is kind. Ashim has also taken his time to share the experience. At some point, we have Dr. Satish, who's going to come in from Singapore to add to our surgical skills. But before that, we have the pleasure and privilege of having Dr. Oak, who is the chairperson of the task force of Maharashtra. And I believe the way COVID has been handled in Maharashtra, it of course has got praise from the Prime Minister himself, but all over the world, I think they are praising for what could have been a terrible tragedy in Mumbai with the experience and wisdom of Oak sir and his team, and the way the administration have actually listened. There are many areas where there are experts, but then somehow it doesn't translate. So exceptional thing. We are thankful to you, sir, for the safety of all the citizens of Maharashtra, and we all remain protected. And thank you for supporting this. We are doing our best, and we promise you that the ENTs will do their very best, whatever area you need us to be. So you could say a few words about before we begin.
Thank you, Ashish. Dear friends, very pleasant good afternoon. And I think this is an important mantle that you have decided to shoulder. COVID for the last 14 months has gone through various phases. It was an unknown enemy, completely uncharted bastions that we have been trudging upon. And then, well, one medicine after other. And then all of us, surgeons as we have been, we're doing anything except our own domain surgery. I think COVID for the first time has given an opportunity to a surgical domain to perform work in their own field, and that is your field, ENT. And I feel that Maharashtra is facing significant number of cases. The official reported figure is to the tune of approximately about 1,500, and I fear that this figure is just the tip of an iceberg. So yesterday, pardon me?
The Mucor cases, you're saying 1,500?
Yes. Whatever I'm speaking today is in the context of mucormycosis. So I fear that there are many more behind them who have not yet come to the surface. And I think I would say in your own words, Ashish, form there, which we need to endoscope and see right across, all across the frontiers of the state. So yesterday, there was a special state task force meeting on the topic of mucormycosis. A paper has been developed with the inputs of everybody, and a protocol has been laid down as how one should approach it in the management. So we have made an appeal that every patient who is in ICU and ready to go home eventually, every patient who has classified himself into the high-risk category of COVID should be subjected to a consultation from an ENT surgeon. If he wishes, preferably once in a week. Yesterday, in fact, people actually said twice in a week, be subjected to the procedures of nasal endoscopy. Ashish yesterday came out with a suggestion of even a brush biopsy prior to a formal debridement and we sending the material for biopsy. MRI, obviously, Ashim was making very valid points. And the paper that Maharashtra Task Force has circulated, a little exhaustive one, almost about 14 pages, talks about all the features of T1 and T2 weighted images of MR, because these things are relatively unknown yet in the interiors of Maharashtra, as far as the radiologists are concerned, and even maybe the ENT colleagues are concerned. Today morning, I had a talk with Honorable Health Minister and Honorable Chief Minister prior to their meeting with Honorable PM. And I think it is clear that the next week is going to be a mucormycosis and ENT concentration week. And this particular meeting on that background is very, very significant. You also go across the paper, because that paper of the task force is being circulated all across the state today. So the various medicines, the dosages, the combination therapy, the salvage therapy, what if lyophilized variant of the antifungal is not available? What do you choose? Whether posaconazole has any role prophylactically and as a suppurative or as an adjuvant, every possible thing has been discussed. But the fact remains that good surgery has no substitute. And I think surgical debridement by an ENT surgeon is now in the forefront if we want to save lives out of nasal mucor going into brain, or a pulmonary mucor, or a renal mucor, or a GI mucor. All these things have been seen in our country. So I won't be long. I wish you all the very best. And Ashish, after the 2 days events of today and Saturday, let's talk again on Sunday, when I will further update the advisory with all possible suggestions included. All the best to you. Thank you.
Only one point. Thank you, sir. Thank you. We are in unprecedented times. See, mucor surgery was a well standardized protocol, but now the absence of an anti-mucor drug, I think we are trying to increase our margins of debridement. And this is what we are going to come out with. That area of suspicion, ho ka nahi, karu ka nako, I think with the another 4 or 5 days. So this next 5 days, we may be doing a little bit more aggressive, but that I'll get Satish, Ashim and others to sort of opine. And that's the minor change which we may suggest to you.
So Ashish, obviously, I mean, the prevention has to be the first role even by all surgeons like us. So one must try and prevent mucor. And for that, one has to treat COVID properly and take care of diabetes and stop unscrupulous use of methylprednisolone and so many steroids. Yeah. But we can't take a second stand of, as was suggested yesterday, of stop prescribing and drop methylprednisolone from it. Yeah. Just cannot be done, because then we would lose lives. Absolutely. So I think a balance has to be evoked. And though we are surgeons, we will say that prevention is the first level of treatment of mucormycosis. Okay. When we fail that, this is what needs to be done. That's how I think we should say about this. Thank you.
Thank you, sir. Thank you very much. Satish, Ashim, you want to say anything?
Yes, actually, the next to be called upon will be Satish Jain and his discussion of the MRI, because I personally feel that till date, MRI has not been given its due place in the sun for the diagnosis of mucor and COVID. What is happening is that most people, even now, are relying upon CT scan alone, and that will never allow us to determine the margin of exenteration and the removal of the debridement that we seek to do.
In fact, sorry, Ashim, often it is misleading. I have fear that when you base your surgery on CT scan, you are actually imagining things rather than seeing things. Sorry.
That is correct, because it's almost impossible to determine whether it is mucor or a routine sinusitis along with a healing COVID. And that is where the role of MRI comes in. So the next few minutes, I think all should be focused on what Satish has to say on the pattern, on the protocol that one should follow for doing the MRI imaging. Because unless this protocol is shared with your radiologist also, it will be very difficult for them also to interpret. Because a routine sinus MRI or a routine skull-based MRI is not going to be enough. So I will, before we go on to Satish, let us welcome two people who I really appreciate in this world of ENT. One is Dr. Dharamveer Sethi, he is just logged in from Singapore. Thank you, Dharamveer, for coming. Welcome to this program. A very, very warm welcome from all of us here. And the chairperson for this program, Dr. Sameer Bhargav, president of the All India Association of Otolaryngologists, has also logged in. So let me welcome both of them. Hi, Sameer, welcome.
Hi, Sameer, hi. Sethi, sir, this is Dr. Sethi that I wrote to you about. He is the master of masters. Anybody who is mentioning in the country has been trained by this great man. Thank you, boss. Thank you for being there. And we are going to tax him a lot because fortunately he does not have mucor. So unlike me, Ashim, Satish and all the ENTs, he has free time and we are going to exploit him. Hamara hak banta hai iske upar. So we are going to say anybody having any issues with reading the MRI, anybody during surgery having any, we will have Dr. Sethi help us out and we will not allow him to sleep. Boss, if you want to say something, just you have to say yes.
No, Ashish, just thank you so much for yeah, getting me on the panel today. It's a privilege to be here. We don't see much of Mucor at all. In fact, I spoke to Leong Honam, who is one of our leading experts on COVID-19. He's on the task force for Singapore, and he said we haven't had any reported case. In fact, I did one more than 25 years ago. I don't even know whether it was Mucor, but looks very much like what you described. And at that time, we didn't have MRI. That was a long time back, and we depended solely on CT scan. So I have been following the Satish surgery and imaging past couple of workshops that he did. Very excited to be here, and if I can contribute something, I'll be delighted to. Thank you.
Thank you.
Samir, from our association, any few words for you to say before we start with the program?
Thanks, Ashim, for inviting me for this. And of course, you all are doing a wonderful job in, if I may use the word, enlightening all the ENT surgeons, not only of the city, but the state, the country, and probably even abroad. Because this being a disease that seems to be more endemic in India as of now, I think everybody needs an enlightenment about this. And thanks to Satish and his last 2 or 3 surgical webinars, I think now everybody who has attended that is going to do only an MRI and not just a CT scan. But having said that, I would definitely probably as a first initial screening, maybe that CT scan is what is being done, because we are also getting at Cooper Hospital a lot of patients from the rest of the state, and we find that most people have done just that CT scan, and then when they come here, then we look at the MRI and really find out how much the disease is actually spread inside. So thanks for doing this wonderful job of educating even the ENT surgeons. And I think over to Satish. I'm not going to take much time. I think everybody is waiting for his talk. Satish. And good afternoon, Dr. Sethi, and good afternoon, Dr. Oak. It's great to see you.
Satish, anybody from Haryana AOI wants to say, or any of your other person from Jaipur?
I don't think they are welcome to
in between,
anything if they want to.
The entire course they can come in. So maybe you
yes, can. Yes, anytime, any point of time. Yeah. So thank you, Ashish and Ashim, my dear brothers, for involving me in this webinar. And big thanks to the chairman, Dr. Sanjay Oak, for this great initiative, and the team AOI Pune and the chairmanship of ever smiling Dr. Samir Bhargav, AOI Haryana, Dr. Master Blaster, Dr. Sudeep Munjal, Dr. Sandhuja, Dr. Upendra Ranga, and all that who are involved in this scientific activity. Thank you once again for giving me this opportunity. We always, like in our previous 2 webinars, discussed a lot about the workup of these patients for mucormycosis treatment. And MRI, as we all have been discussing, has come up as a principal tool to work up all these patients. So imaging of choice is MRI for certain reasons, which I'm now going to, enumerate why MRI is distinctly superior to any other investigation. Why we want to do MRI? This mucormycosis is a different disease which preferentially invades the vessel and give vascular necrosis.
Sorry, get your mic right. Thoda niche gaya.
Yes. So this mucormycosis is a different disease which preferentially invades the vessels and give vascular necrosis. Role of MRI, I call MRI in this particular disease as a bioimaging, which truly differentiates the tissue what we are going to deal with. And why we need this differentiation? We want to know the tissue which has got necrosed because of lack of vascularity so that we can remove it, where the drugs are not going to penetrate. And the surgery has a principal role in removal of their disease, necrotic tissue, to facilitate the medical treatment, to promote the penetration of medical treatment to the viable tissues. So the MRI should be able to differentiate what is necrotic. Any investigation should be able to differentiate what is necrotic tissue which needs to be removed and what is not necrotic tissue. This is one part, one aspect we need to see from MRI. Another important aspect is where all the disease has spread to, so that we can plan our surgical approach, we can prognosticate the patient. Patients having minimal disease, you can give a best prognosis as compared to those where the disease is extended intracranially or anywhere to the difficult areas, which is not difficult to remove. And those are the patients carry the poor prognosis. So MRI can clearly tell you pre-operatively how the patient is going to behave by and large post-operatively. Number 3, the critical areas involved, which requires special attention during surgery, like orbit. Exentration, clearance of the orbit is totally dictated by MRI. MRI gives, by means of its versatility, by means of its ability to give more than 1500 sequences, it can really differentiate soft tissue into different types. So it gives us amazing information about the patient's vision status, the optic nerve status, orbital involvement, need of the orbital clearance, need of the orbital exentration, very clearly, which I am going to show you. And if there are any distal spread of disease which is happening even before the clinical appearance, if the patient is developing some distal spread, you can warn your patient beforehand rather than developing that complication later on and finding some medical legal problems. So you can, by means of MRI, pre-operatively, you can assume that what complications are going to happen. That is so important. Next is about the vascular spread. This disease has an affinity to spread through vessels. Involvement of the carotid artery, cavernous sinus is not uncommon, and those are the most difficult areas to deal with. And MRI has the ability to clearly appreciate, give information about what exactly is going on with the central circulation and the cavernous sinus and all that. So you can plan your surgical approach and prognosticate your patient accordingly. Yes, Ashish.
Even if the vision is normal and the eyeball movement is good,
yes,
I think we can come out with an algorithm or something that MRI is preoperatively. And will you dwell on it now?
Yes, exactly. MRI can tell you. That's what I'm going to discuss. Then there are certain areas, as I said, necrotic areas have to be removed to facilitate the medical treatment. There are certain areas where your surgery can lead to a lot of morbidity, like involvement of the hard palate, which is not uncommon. And pre-operatively, your MRI can easily pick up, and you can tell your patient pre-op that this will need to be debrided, which will require later on reconstruction and other treatment, and will have some sort of morbidity, and you can alert your patient beforehand to that treatment rather than giving your patient post-operative number of surprises. So MRI has number of roles to deal with, and I am going to show you certain first of all the case which we are dealing with today. What are the sequences we need to order for MRI? Because the onus is on the surgeon. If you write MRI PNS, your radiologist will do 1 or 2 sequences and finish MRI in 5-10 minutes. You have to order particular important sequences for particular disease. That onus is on surgeon. And that is what I am going to enumerate, what sequences are important and what information do they give for mucormycosis treatment. So number 1 sequence is the fat suppressed T2 weighted MRI. Fat suppressed T2 weighted MRI gives us complete information about this inflammatory disease. See, this is infection. Infection is always bright on T2 weighted, like any fluid. Any tissue with water content will appear bright on T2. And the second sequence I will compare together is a contrast. These 2 sequences will give us majority of the information, and we can keep them together on if you have a complete data of the MRI, and that's why we always acquire our MRI on DVD. So I will put up these 2 things together, and it will give us most of the information and how to see that and what all to be seen. As I said, it invades the vessel and gives vascular necrosis. When there is vascular necrosis, whatever contrast material you give, gadolinium, is not going to reach those areas which are normally enhancing. Now see on this contrast sequence. See the turbinates on the right side. I hope you can see the MRI.
Yes, we can see.
See the turbinates which are enhancing on the right side, and look at the turbinates and the lateral nasal wall on the left side after gadolinium administration, which is not enhancing, which gives you a clear picture what exactly is necrotic tissue which needs to be removed. So the contrast picture will give you information about the necrotic tissue. It is not only the necrotic tissue that needs to be dealt with. Enhancing tissue also needs to be dealt with because that contains the fungal load. But since the gadolinium is reaching, so we expect our amphotericin will also reach, which is deadly to the mucor. So those areas we are not supposed to radically remove to give more and more morbidity. Rather, we can stay conservative on those areas and expect the amphotericin to work on those areas to avoid unnecessary morbidity of removing everything. Yes, Ashish.
Sorry. Now we are in a phase where we are not having amphotericin for, let's say, 5 or 7 days.
Yeah.
How do we deal with these areas?
So, Ashish, let me tell you, this is a medical disease. This is a fungal infection. This is not a surgical entity. Role of surgery is limited and very important to remove those necrotic gangrenous areas which can't be dealt with the medicines. Which are the areas of fungal load, which are the areas where fungus has a particular environment, the best environment to thrive. The acidotic, non-hypoxic areas where the fungus can spread to the adjacent areas very fast. And role of surgery is to deal with those areas. Rest is a medical disease which you have to deal with the medications. Unfortunately, liposomal amphotericin is temporarily short.
If we are not going to get the amphotericin or any anti-mucor drug,
volume badana.
Currently, like maybe hopefully next 4 or 7 days, we are not going to have an amphotericin.
Yes.
Patients, would you recommend that we also debride this tissue, which is enhancing?
Okay, let me tell you what you are trying to say. See this entire infratemporal fossa area, which is enhancing behind. Can you see?
Yes.
Yeah. If you try to remove everything, you'll end up leaving nothing in that certain areas, and you will end up giving a lot of morbidity, which is not a good idea. Amphotericin might be short for the time being. We are facing this crisis, but time being we have to resort to the alternate drugs, and ultimately this crisis is going to be over.
So don't overdo the surgery. Don't overdo the surgery. Stick
yes, that morbidity is significant. You can't remove the entire contents of the infratemporal fossa like anything and leave a permanent morbidity to the patient. That is not acceptable. So what I'm trying to say, this is a contrast picture where you see loss of contrast enhancement. Loss of contrast enhancement is the sign of the area which need to be debrided. And what you see on T2 weighted MRI, it is enhancing because it has water content. Inflammation has water content, which is always enhancing on T2. So keeping these two sequences together, you can have a full idea. Three-dimensionally, in all planes, you can see where all are the necrotic areas need to be removed. So you can plan your approach accordingly. I will show you some example where the disease has gone to the superficial skin, and you can't remove those cases, debride those cases endoscopically, and you have to resort to an open approach when it comes to removal of the skin. When it comes to removal of the eyelids, other facial structure, you need to resort to the open approach. So this involvement on the MRI, what is shown on the MRI, what areas are involved, is the surgical approach is dictated by the MRI, whether you can remove by the endoscopic or open approach, or whether it is inoperable according to the surgeon's competence. That you can take a call according to the extent of necrotic area. Number one. Number two, see from anterior to posterior, you can see the maxillary sinus, nasal cavity, the ethmoidal cavity. See this entire ethmoidal cavity is all full of necrotic tissue, which is enhancing on T2 and not enhancing on gadolinium. Then the orbit and the adjacent area need to be seen. The skull base. See, the disease is reaching right up to the skull base. You can see. Right up to the ethmoidal skull base, you can see, but not breaching the skull base, you can see very well. Can you see on T2? The skull base bone is completely intact, and disease is not transgressing that skull base barrier to invade intracranial structures. Then posteriorly, this is your pterygopalatine fossa region, and disease is there in the pterygopalatine fossa. You can see the bunch of disease is in the pterygopalatine fossa. Bunch of disease there, and there behind behind. This is the infratemporal fossa, where a lot of enhancing area, that is a good sign. Whatever necrotic under vision you can remove, and whatever enhancing area, the inflamed muscle you are not supposed to remove. What enhancing areas are? Inflamed areas. You will find the muscles in the infratemporal fossa, non-necrotic but inflamed. And we are not supposed to remove that radically. We can expect our drug to penetrate those and work there efficiently. And this is the pterygoid process area. That is the pterygoid process area where the disease is, oh.
Satish, how often, in what percentage is the pterygopalatine fossa involved in your?
Very common. Very common. More than 70%, more than 80%, I would say. And in advanced diseases, particularly when it invades the orbit, it is almost always involved. And this is one of the avenues for the infection to spread to the orbital apex and give early blindness. I will show you the close anatomy of the pterygopalatine fossa, orbital apex, and the cavernous sinus. This 1 square inch area is the key area where this mucormycosis spread so fast. In no time, it gives blindness. In no time, it invades the intracranial structures through that avenues, through those channels. So this is the spread of the disease in that area, what need to be seen on these two MRIs. Now the next is...
Sorry, sir is there, I want to clarify. This cannot ever be seen on a CT scan. To be able to predict this, to be able to read this, you only and only need the MRI.
Yes, yes. So what I will do, let me explain the MRI, and I'll bring the CT scan later, and I'll ask you to give me what information you can give us. We'll discuss the CT scan later.
Take my exam.
I will bring some CT picture later of one of these patients. So now come to the orbit. We need a lot of information that this disease has a propensity to involve the orbit at the early phase and give blindness. Even with the minimal disease in the nose and the, the sinuses and the maxilla, patient present with the blindness because it has a affinity to invade the vessel, and central retinal artery occlusion can lead to early blindness. Other way of blindness is involving the orbital structure, involving the optic nerve itself. Inflammation of the optic nerve is the principal reason for giving blindness. And how can you pick up? Sometimes you have a patient who present with blindness. Now, you are safe. You have nothing to save. And some of the patients are in the early phase of developing blindness. The moment you start treatment, the next day patient develop blindness, and the onus is on the surgeon again. The patient may start blaming you that if after starting my treatment, I developed the blindness. And this can be certainly avoided to a certain extent by means of MRI. You can see what is happening, the level of inflammation in the optic nerve. For example, this patient, I tell you one of the simplest sequence. I must reiterate on this to everyone watching this webinar to get this. You must get this sequence done to pick up the early presentation of blindness, early involvement of the optic nerve and the blindness. Let me show you first, and then I'll come back to this. Let me show you one diffusion weighted MRI sequence. Diffusion weighted MRI, I always tell, diffusion weighted MRI is a bioimaging. Diffusion weighted MRI is a bioimaging by means of which we can see the molecular diffusion, water diffusion in the tissues, water molecular diffusion into the tissue. See this diffusion weighted MRI. Keep an eye. This patient has a blindness on the right side. I'll show you how it is involving the orbit. Simplest of all sequence, diffusion weighted MRI, and what you see, this optic now on this side having infarct. Diffusion weighted MRI is a sequence which can pick up earliest the infarct. It can pick up earliest the developing infarct even before it clinically presents. Even before it clinically presents. So you have to assess the entire cranial cavity. See, some infarcts developing bilaterally into the temporal lobe. Can you see?
Yes.
And a big infarct in the optic nerve. Looking at this sequence, I can tell my patient without even looking at the patient clinically, without even asking, that the patient is certainly blind. So we must get the diffusion weighted MRI to see the optic apparatus, to see the visual status. And by means of visualizing the earliest infarct in the optic nerve, you can certainly say that the patient has lost the vision.
So
Even
this
before.
is not impending, Satish. This is already a blind, already clinically blind.
Yes.
But if
even before the patient says he is not completely blind, say I have some diminished vision. With mucormycosis in the orbit, with mucormycosis in the orbit, and you find the infarct developing in the optic nerve, you can tell your patient you have practically lost your vision and there is no possibility of saving the vision. This is irreversible for that matter. So diffusion weighted in one sequence, we must always get done. Coming back to the same sequence, these two sequences. So we were talking about the orbit. Now, look at on T2 weighted MRI in this orbit on both sides. Can you see the difference in the right orbit and the left orbit?
yes.
Yes.
What sequence is this? This is fat suppressed MRI. T2 weighted fat suppressed MRI. Why so? Orbit is full of fat. On any MRI sequence, the fat is always bright. Inflammation is also bright. With a fat signals inside the orbit and inflammation superadded, you can't differentiate whether it is inflammation sequence or fat sequence. So, fat signals. So, what you do, this is fat suppressed MRI where you suppress the fat. Now, whatever high signals are going to be purely related to inflammation. Got my point?
Yes.
Now, look at this fat sequence MRI on this side. First, focus on the right side, and it is completely non-enhancing. Can you see?
Yeah.
Now look at on this orbit. Everywhere inflammation. See the deep inflammation at the level of the orbital apex, and I will show you once I explore. I know before I explore that this eye has gone completely necrotic. This orbital apex has gone completely necrotic, and most of the regions have gone necrotic by means of showing this inflammatory areas in the orbit. And see what happens once you show inflammatory areas. Some of them are enhancing, some of them are not enhancing on contrast, which signifies that the mucor has invaded this orbital space. And if you go behind, see the mucor has completely invaded the orbital apex. So this is the case for the orbital clearance, which I am going to show you endoscopically, not for orbital exenteration. A lot of people even publish in the newspapers that they remove the eye so frequently. Eye need not to be removed so frequently. In less than 10% of our huge series of cases, we need to exenterate. Only when the outside structures, the eyelid and the globe is directly invaded, then only you need to do an orbital exenteration. That is two radical procedure which were initially developed for treatment of the malignancies involving this area. This particular disease, the concept is different. We have to remove only those necrotic areas where the drugs are not going to reach, and to preserve those areas, healthy areas, vascular areas where the drug can have its own effect. So here we will be doing an orbital clearance. Now,
sorry, I mean, folks, yes. So enucleation is very, very rarely required in a mucor case.
Enucleation is a different word, Ashi. Enucleation is removal of the eyeball.
Yeah.
Here we are not concerned with removal of the eye. Our concern, again, don't deviate from our aim. Our aim is to remove the necrotic tissue, whatever it comes. If the eyeball is necrotic, I have to remove it.
Sure.
So rather than using terminologies, exenteration, enucleation, evisceration, the best and appropriate terminology is removal of the necrotic tissue, whatsoever it is. And for that, even if you have to exenterate, we have to do that if the outside structures like eyelids and the skin is involved. Not for the involvement of the retroorbital tissues that you need to do orbital exenteration always.
Trying to bring forth the limited role of an oculoplastic surgeon. In mucor, we almost don't need them. Almost.
Absolutely. Now, another way of looking at the vision, whether the patient, how the patient's vision is going to be. Look at the other side. Can you see right from the beginning? See, this is globe. This is optic now. Can you see?
Yeah.
On the right side, what is there on the left side? See, what is this white halo around the optic nerve? Optic nerve is here in the center. What is this white halo? This is the perioptic CSF space. The optic nerve carries the meningeal sheath right up to the globe. We all know. And this is the sheath which is full of CSF, and that signifies a good signal of the optic nerve CSF on the right side, which is practically nowhere on the lost. It is completely lost. See, anteriorly, just behind the globe, it starts and then it fades off, completely gone. You can see on the right side intact, but it is completely gone. I can follow it to the level of the chiasma. This is chiasma, optic chiasma, and see on this side. See, this is the optic now. This is the optic now, and this is completely gone. By this side, you can see the optic nerve. So this is third way of assessment of the orbit. Number one, diffusion weighted to see the optic nerve infarct. Number two, fat suppressed MRI to see the intensity of inflammation in the orbit and the areas of the inflammation into the orbit. And number third, on the T2 weighted MRI is the perioptic CSF space. By means of these, you can, prognosticate the vision and plan your surgical approach to the orbit. And in such a case, again, my approach would be intraorbital, endoscopic orbital clearance rather than an exentration. So this is not the case for the exentration. This is the second thing that you need to see on MRI. Now, when this was I already mentioned, the earliest in any case, you will find this sign, black turbinate sign. So whenever you start, looking at the mucor in mind, must look at the turbinate. The turbinate, which is non-enhancing, black turbinate sign is the earliest one. And that is classical for the mucormycosis. Now, some of the areas which I will show, which is not in this particular patient, which need to be assessed in every case. Like, for example, the involvement of the cavernous sinus, involvement of the carotid artery flow. I will show you some examples. Intracranial infarcts. If they are, you have to counsel your patient for that prognosis. We have a couple of patients whom we have been treating for mucor have already developed intracranial infarct with not much of the symptoms that you have to keep in mind for prognostication. So some of the examples I am showing from different patients on the MRIs, and then involvement of the soft tissues, involvement of the palate, you can completely predict, as I said. So one by one, first of all, I will take the cavernous sinus involvement, okay? So this particular patient, let me show you the minimal involvement of the cavernous sinus. This is a revision case operated somewhere with lots of disease behind. Let me show you first. What is the status of the disease after the surgery? Look at this. Look at this, the disease removal during primary surgery. Almost nothing has been done. And see, this is all non-enhancing area, the skull base. And the most important is this non-enhancing area. This is greater wing of the sphenoid. This is pterygoid and the sphenoid bone, which is the most dreaded area, most difficult area, which needs to be completely debrided. And we all know the carotid artery, cavernous sinus in the close vicinity at the orbital apex. This is the most difficult area. Now see, as I go behind, this is the carotid artery. This is the carotid artery, and this is the disease right into the cavernous sinus. How to know whether the cavernous sinus has undergone thrombosis? Let me show you the axial picture. Look at this axial picture on this side. Can you see the difference on both sides?
Yes.
See the carotid artery and the cavernous sinus on this side. And what is happening on this side? You lost the signal. No enhancement, and this is a classical example of the cavernous sinus thrombosis. And keeping this fact in mind, we need to, start early the anticoagulants. Operating on these patients is a dual challenge with anticoagulants, need to be started as early as possible to prevent the further thrombotic episodes. So this has to be seen on every MRI, on every mucor patient you are treating, whether it is a minimal disease or extensive disease, because it has a tendency to invade vessels very early in the course. See what I'm showing on MRI in detail. It is the onus on the surgeon to see himself. Don't rely on the radiologist too much. Radiologists don't have time to explain you hours and hours. Believe me, they will just write a report of, this thing, this area is involved. How surgically it is relevant is you have to correlate. So we have to develop this habit of reading MRI on to improve our results, to predict and to prognosticate the patients well. So this is the cavernous sinus thrombosis on this particular patient. See this. The entire non-enhancing area in the disease is right invading the cavernous sinus, which is the Herculean task to remove it, and we are going to do it soon. So probably we'll keep in one of the webcasts. We are showing the variety of cases. Pardon?
What surgery was done before on this patient?
Mucormycosis surgery.
Achha.
You can interpret yourself, but this is mucormycosis surgery. Now, just a minute. I will show you some important.
One of the biggest fallacies of doing the surgery is that during surgery, the posterior wall of the maxilla appears normal, and therefore the surgeon stops there, not knowing what is lying in the pterygopalatine fossa and towards the infratemporal fossa. So that is the value of the MRI. In most of these cases, as Satish earlier said, 70 to 80% of cases, the posterior wall of the maxilla should be removed to examine the contents of the pterygopalatine fossa and going laterally to the infratemporal fossa, because that is the residual disease. That's where it grows back from.
So there are lots of things to be assessed on MRI for your, overall treatment. Everything is important. Prediction and the prognostication is an integral part of your overall treatment. Otherwise, failure to do so can take you any time in the medical legal complications. So this patient, very interesting, let me show you first the disease profile. This is a post-surgery. Can you give me the other one? The pre-surgery, yes. See, this is post-surgery, the clearance. Can you see?
Yeah.
Can you see the clearance, everything?
Yep.
Now let me show you pre-surgery. That is an important point to keep in mind, because these patients have to be dealt with. Oh, come on. Yes. So this patient had carotid artery occlusion before. Complete occlusion of the circulation on one side with some weakness on the opposite, limbs, and had extensive mucus. I have already shown you post-op. Yeah. So if I show you this axial contrast MRI, it's opening. It is opening. Just a moment. That's a very interesting finding. Where is the... Why it's not opening? So this patient had a complete occlusion of the carotid artery, which I wanted to show you. No flow of the carotid artery on one side. Complete occlusion of the carotid artery on one side, and patient presented with hemiplasia, hemiparesis. So that is one thing we must always keep in mind in such patients, that such possibility can always be there, and we have to be very, very careful. Now, certain examples of orbital involvement. Yes, certain examples of orbital involvement, what we discussed before. Same picture, just to give you repeated information that how predictable it is. See the T2 weighted fat suppressed MRI. Can you see the difference in both the orbits?
Yes.
See, this is fat suppressed image and see the kind of inflammation. Kind of inflammation this particular patient is having in the orbit with no optic nerve signal. See the optic nerve signal gone. So these are the patients need to be thoroughly assessed with the angiogram. You can get the MR angiogram done to see complete information of the vascular. I would show you one of the angiogram. This is, see this, the infarct in the optic nerve on the right side. Can you see?
Yes.
On this right side where the patient has lost vision, and see the amount of disease in the right eye with this much of the inflammation. So orbital involvement requires diffusion weighted, T2 weighted fat suppress, and the perioptic CSF space halo, which all are important to assess the orbital involvement. Now, another important thing is the palatal involvement. Palatal involvement is very important. The early palatal involvement can, warn you from regarding the, reconstruction facility. Shravan Kumar. Yeah, this is the patient probably as an early palatal involvement. See, if we miss this finding on MRI, we may not counsel our patient your palate is probably involved, and intraoperatively get a surprise that the mucor has invaded the palate, and you have to obviously nothing else then but to exenterate the palate and tell your patient post-op with a big surprise that we had to remove the palate, and now you'll have to undergo some other treatment for the palate in the future. See this. This is the palate and this is the palatal periosteum, the mucosa. Can you see on the difference on both sides?
Yes.
One side is enhancing, and on this disease side. This disease side, the palatal mucosa is not enhancing, and that is a great sign you can pick up on MRI that the palate has already been invaded with the mucor, and you have to plan this, removal of the palate in your the surgical process. So palatal involvement has to be picked up. These are the areas which can be easily missed. Another example, and you have to see on contrast MRI. Again on contrast MRI, see this. Can you see the difference? The non-enhancing area and the enhancing area of the palate. Can you see?
Yes.
See the disease on this side. See the mucor on this side, and see the palate is already invaded. Non-enhancing area in the palate. Can you pick up this? Can you appreciate this?
Yes.
And this is how you can plan the removal of palate, which may not be obviously, assessed by other means pre-operatively. You can't assess many a time unless you have a palatal, S-char or a palatal ulcer. And many a time it can be overlooked on clinical examination, which MRI can pick up early, and you can tell your patient or the need of possible palatal reconstruction later on. Now, the involvement of the soft tissue areas. This is the very, very important scan by means of which we can plan our surgical approach accordingly. Like there are certain areas where the open surgery is required. Now look at this. This patient, I will show you the picture of this patient whose disease had invaded the facial soft tissues, nasal ala, eyelids, the orbital contents from outside, everything invaded by the mucor. See everywhere. Everywhere the ala and everything involved. Completely involved. See the soft tissues, the anterior wall of the skin and everything all involved along with the eyelids. And these are the candidates for the open surgery, orbital exenteration, as there is already huge disease in the orbit, rather than a sole endoscopic approach to give a complete clearance. So your radiology can tell you what exactly need to be done, and MRI by means of, so much of, information, so much of sequences, variety of sequences give you complete information. Look at the orbit again. Orbit on this side and orbit on this side. Now, Ashish, coming to your question, early involvement. with the vision intact, what to do? See this side grossly gone, completely gone, and this side early involvement orbit.
Oh yeah.
See, this is already inside the orbit, but the vision is completely intact. Look at the optic now. Look at the optic now on the other side. Now what to do? How to take a call whether this other eye can be saved or not? Diffusion. Diffusion will tell you what exactly is happening. See, on diffusion, there's an infarct in the optic now on the other side, and the infarct developing in this optic now. The patient has mild diminution of the vision with minimal involvement of the orbit, with an early infarct developing in the optic now. Even if you try to preserve such optic now, the patient may not be able to preserve the vision, and vision is most likely to go along as the early infarction is already developing. So such patient where the vision is already gone on one side, lost the vision on one side, the other side clinically vision looks good, but inside the early infarct is happening. You have to be very, very, important, particular in counseling the patient. In spite of all odds, you may not be able to save the vision. Otherwise, post-operatively, if the patient loses the vision, he may, blame you for this, complete blindness. So you have to be very careful. Always get the diffusion-weighted MRI done to get a complete information of the optic now. Got my point?
Yes, Satish. Very nice. Thank you.
See how MRI is now. What information you got from the MRI? How much you get from the CT scan? Let me show you. This is a CT scan of a patient. Let me show you. This is a CT scan of the patient. Of a mucormycosis patient. Now see, what is the difference in this CT scan from the CT scan of a plain simple sinusitis patient?
Yeah.
How much you can differentiate from the CT scan? How much the optic nerve is involved, how the orbit is involved, whether you can save the eye, any infarction, involvement of the bone, involvement of, other areas. This is practically impossible. So the CT scan gives to me just nothing. As good as useless to get a CT scan, unnecessarily subjecting the patient to radiation before mucormycosis surgery. There is no point. It will not give you information whether how the pterygopalatine foci. See this opacity there. That doesn't differentiate whether it is enhancing, non-enhancing, mucor, simple inflammation, sinusitis, what exactly it is. So it is as good as useless information you get from the CT scan. Now another areas, the drilling into the sphenoid. Drilling into the sphenoid, let me show you. I want to show you one more scan before we proceed to the surgery. That is a very, very important, information we get out of that. Anyway, I can show you the other one. How much drilling is required into the sphenoid? What exactly the drilling required in the sphenoid? The level of drilling required in the sphenoid is very, very important. Now, otherwise, the principal cause of failure of this surgery, principal cause of poor prognosis is the necrotic bone left behind. The bone which is undergone osteomyelitis by means of involvement by the fungus, which is lacking the vascularity, which has no penetration of the drugs now, and if you leave that bone behind, that bony osteomyelitis, there is nothing, you can say that you can save the patient. See this. This is a huge disease with a huge necrotic areas into the sphenoid. There's a carotid, sphenoid, huge necrotic areas, and this invaded bone is hyper intense. If you leave that bone behind, your drugs are not going to penetrate, and this is certainly what you can see the prognosis you can expect is a very, very poor prognosis for these patients. So leaving the necrotic bone behind, in spite of doing a good work, is not going to help you. So this particular surgery in the mucormycosis requires a complete exenteration of the necrotic tissues, particularly the bone, particularly the sphenoid bone, the parts of the sphenoid bone which are very frequently involved, the pterygoid, the sphenoid floor, the greater wing of the sphenoid, all those areas are very frequently involved, are most difficult to remove. You must assess with the MRI what all need to be removed, what all need to be left behind, and according to the competence, one has to take the case and tell the prognosis to the patient. See, the normal sphenoid wing, see, this is the temporal lobe of the brain. And in the base, what is that on the normal side? Greater wing of the sphenoid. Greater wing of the sphenoid being black on normal contrast administration. Okay? Now on C, the greater on the wing of the sphenoid, owing to its content, that is bone marrow, which appear bright on T2 weighted, normal side. I am showing you normal side. Normal side on T2, bright due to bone marrow. On contrast, dark due to non-enhancement. Now you see on the opposite side what has gone. See, on T2, the entire bone marrow is gone and it's replaced by this disease right up to the most lateral aspect. When you are going endoscopically, you have to go right away there until the temporal dura to drill off this bone completely. Otherwise, it is not going to help you, whatever surgical work you have done. So you can assess with the MRI that how much the drilling is required. How laterally, see, this is the temporal dura and this greater wing of the sphenoid is completely invaded. Another thing, the involvement of the dura. This particular patient, look at the dura on this side. See on contrast. And look at the dura on this side. See this dura. It's thick and enhancing. Can you see the temporal dura?
Yeah, very good.
And see the temporal dura, normal. And this is the fungal meningitis developing involving the dura. Why it is important? In any meningitis case, may not be fungal, in other meningitis case, or we intend to give our, injection for at least 3 to 4 weeks for complete clearance of the disease from the dura, infection from the dura. And here in cases which develop fungal meningitis, you are at the mercy of liposomal amphotericin B. And this is the indication where the amphotericin B need to be administered for almost a month. In other situation where we operate in a regular case when the dura is not involved, and if you have done an adequate clearance of the necrotic tissue, you practically don't need amphotericin for more than 7 days. In most of the situation, you don't need more than the 7 days. So patients, unfortunately, in this crisis of, non-availability of amphotericin B, there are certain, lack of guidelines, which has, worsened this crisis of amphotericin B non-availability, because many of the patients are receiving amphotericin B in ICUs, in other non-surgical settings for weeks and weeks without removal of the necrotic tissue, and that entire amphotericin B is going, complete waste. Then non-removal of the, necrotic tissue completely. If you don't remove the necrotic tissue completely and want to cover with a long duration administration of amphotericin B, is never going to work. It is the most wanted thing is a complete removal of the necrotic tissue. So the need of the amphotericin would be less and less rather than administering for weeks and weeks. This is the only indication where amphotericin B is required to be administered for more than 3 or 4 weeks to completely resolve the fungal meningitis, which is ominous otherwise. So these are certain highlights, certain points you can assess on MRI of every patient. You must get all these sequences done on the DVD and touch upon all these issues separately to have a complete workup of mucormycosis patient before you plan any treatment, surgical, medical, so that you can give the optimum results and you can prognosticate the patient properly. So you must sit at least in half an hour with the MRI for every patient to get the complete information. Otherwise, the treatment will be full of surprises. You will find that I have under the misconception that done an adequate clearance, and this disease is so bad, this is coming back again. Lack of proper workup is the principal cause of failure in this particular surgery, in particular disease. Anything, Ashish, you want to make before I start? Or do I go with the MRI further and I think it is enough?
No. Let's start the surgery because
Dr. Satish, can I ask something?
Yes, please, sir.
Yeah, I am Dr. Prakash Munka. What I am asking is, you stressed so much that MRI, and that get contrast.
Sir, I am not manufacturing MRI machines.
Sequence.
It is important for patients.
Yeah.
The distinct advantage given by the MRI is amazing.
Exactly. I agree 100%, and having listening you since couple of days. Now tell me the people who don't have access to MRI, because CT is hardly inadequate in information. MRI not only gives the structural, but
CT
as well as
is as good as useless as compared to MRI.
Yes.
And
so the people who are working at
with the lack of information, lack of workup, one cannot expect good results. That's why in literature, many of the literature, the mortality rates are up to 80%. That is the literature where the MRI was not even mentioned. What can you expect in the terms of results? So 80%, I would say it is almost 100% certain mortality if the proper workup and proper clearance is not done.
I think
this disease has 100% mortality if the patient is not treated. As simple as that.
So
100%
we can
mortality.
safely make this statement that MRI is a must in all cases before taking up for surgery.
Yes.
Yes.
That's what the actual workup is.
Okay.
That is the
Dr.
ideal.
Satish, can I ask you one question?
Please.
Dr. Satish, this is Gauri here.
Yes, Gauri.
Dr. Gauri.
Everyone recognizes your voice.
Melodious voice.
No, I wanted to ask one question. That after doing MRI, after doing adequate clearance, and now we do not have amphotericin at our hospital.
Yeah.
And at least for 2-3 days or 5 days, we are not going to.
Let me tell you what we have been doing.
So how do we manage these cases? Should we repeat MRI again?
So I would say that is a different aspect, the medical treatment aspect. And we are going through difficult times where, the Sanjeevani booty, the liposomal amphotericin B is not available freely. So what can we do in these times? Number one, now the surgical clearance has become more important. Number one, more and more important. Number two, you can use the other preparation which are not having that much of penetrance as compared to the liposomal amphotericin B, like deoxychelate and lyophilic and other preparation of amphotericin B, is still as having some value along with other drug posaconazole. So a dual combination can work to some extent.
No, Satish, I am asking you.
After that,
we are not getting even full.
And after some time, post-operatively, we are focused more and more on topical application of amphotericin gel to all those areas, all those inflamed areas to work to some extent. That's what you can do.
But I will take this opportunity to say do not use voriconazole or mycophenolate.
And since we are not getting amphotericin, we are discharging the patients. We are calling them back for follow-up. They are just doing douches. Nothing else is available now.
So, Gauri, you can see the...
So, after how many days we should...
markers.
Yes, the other preparation of the amphotericin B are still available. Posaconazole is not as difficult as liposomal to get.
Difficult to give it in diabetics.
Yes, yes. And all these patients are almost always diabetic.
No,
Yeah. And the third thing is the isobuconazole in certain patients.
they have renal problems.
Start the surgery and answer questions, please.
Yeah. So isobuconazole is a good drug. Cresemba, very popular, can be given even to the renal patient as it doesn't have renal clearance. It is quite reliable, as far as the competence is concerned, not as good as liposomal amphotericin B. But yes, in this difficult times, you can use an alternative with some combination. You can use Cresemba with posaconazole as a combination with more and more emphasis on complete clearance. There is no substitute to complete clearance. Even if you have liposomal amphotericin B, that is not a substitute to complete clearance.
Correct. My question is, should we repeat the MRI if we are not giving any amphotericin? After our clearance, after how many days we should repeat?
So I mentioned last time also, there are certain criteria we take into account to order a repeat MRI. Number one, the clinical course of the patient. If some new clinical thing developing that warns you that the disease is progressing, you might have left behind or the drugs are not working or whatever, the disease is progressing. That is number one. Number two, your endoscopic picture in the post-operative days. If some more necrosis is happening, some more new areas are being involved. Number three, your inflammatory marker is rising in spite of all treatment. Your CRP is, constantly shooting up. So these are the indications to order a MRI to see if anything is left behind or new thing has developed. And you can consider a repeat or a revision surgery in those cases for more complete clearance. So there are definite indications for, repeat MRIs. But based on all these endoscopic, inflammatory, new symptom, new signs, and all these markers, rather than indiscriminately, unnecessarily ordering an MRI. Many of the patients or CRP is gone down below 10. There is no point in doing anything. Just forget about the MRI. Any more questions?
Go ahead, Satish. Go start the surgery.
Okay, so in a couple of minutes, we are coming back with the endoscopic picture. And meantime, we can take questions.
Satish, you want to say?
We can have Satish sir's opinion, the big boss, grand teacher of all, including us. Big boss, anything to say? Any advices or anything, do's or don'ts regarding MRI or anything?
No, Satish, excellent presentation. I mean, you really crystallized it all. I think everything that you said can actually be crystallized or condensed into a sort of a checklist, which can make it easier for people who are not very familiar with MRI scan to go through it systematically, looking for the signs of mucormycosis. For example, you can start off with the nasal cavity, look at the inferior turbinates, give the sequences like T2W sequence, which is fat suppressed, and the T1 weighted with contrast, and what to look for. So first of all, look in the nasal cavity, look at the turbinates, look at the signs of mucor, and then look into the sinuses, paranasal sinuses. And then, like you mentioned, in particularly the infection, a mucor infection can spread out of the bone where the infections are concerned. So you look at the parasinus areas. Then into the infratemporal fossa, then the pterygopalatine fossa, in a very systematic manner, according to the involvement, the common involvement areas. So, and the palate. Then after that, you can look at the orbit, retrovalvular area, optic nerve, and go on to the cavernous sinus. So maybe this can be done in a very systematic manner so that the person who's reading it can do it, sort of more systematically and read it adequately. So that's the only information, comment I have. So very nice. I mean, you have wealth of a material here. I think you will never find this kind of material in any book. And what I've learned in the past 3-4 days about mucormycosis, I couldn't have found it anywhere but in the library of Satish Jain's webinars. So thank you very much.
Thank you, Seti. It's always a great pleasure to hear you. To answer you further, Gauri, one should resist the temptation to give the other antifungals like micafungin, like voriconazole, so on and so forth. And also the good emphasis on anticoagulation is a must. Not by using your usual ecosprints, but by using anti-10A inhibitors like rivaroxaban or apixaban. The another point that one should also not neglect to mention is the fact that during this the use of, if you have intracranial spread and you have you can use deoxycholate amphotericin along with caspofungin, that can be used. It is known to have a good synergistic effect. And so it's very important also not to use iron chelating agents. There is this false idea that by using iron, because mucor requires iron to grow, therefore people have used iron chelating agents, but there are n number of studies that have shown that desferrioxamine has actually increased the mortality following its use during mucor cases. So iron chelating agents also should not be used.
Boss, this free iron is available only when there is hyperglycemia.
Exactly.
So the sugar control is a priority rather than targeting the iron. So sugar control in these patients, see, the control or the treatment of the underlying cause is most important thing. And in these cases are hyperglycemia. So are you getting the endoscopic picture?
Yes, we got the endoscopic picture.
See this patient left eye.
The huge
left eye we have seen. See, left eye of this patient has been involved. I have shown you on MRI.
Yeah.
You remember, which requires orbital clearance. Orbital apex is completely necrosed. I have shown you on MRI. So this is the redness, the proptosis, and the globe is normal. You don't see the eyelids, globes, all are normal. There is no fun in, doing, no point, I would say, criminal to do an orbital exenteration in such cases.
Yes.
So, orbital exenteration is certain indication I have already mentioned. Now, this is the initial decongestion. We have already seen this necrotic areas on the lateral wall. Can you see?
Yeah.
Which we saw on MRI as non-enhancing area. See this?
Absolutely.
Black turbinate.
Black turbinate.
That is the initial thing. See turbinate, middle turbinate behind involved.
Yes.
So, early pickup of this disease is the best way towards cure. So, majority of these diabetes patients who get this, we need to make them aware. If they develop any excessive crusting, you saw the crusting there.
Yes.
Any excessive crusting in the nose in a diabetic patient, it should alert you with mucormycosis underlying in that particular patient. The reason is this lack of vascularity ischemia causes the crust to form, and that is the principal earliest presentation of this mucormycosis you can pick up, which is the best time to cure these patients rather than spreading after it has spread to the orbit or to the cranial cavity. So this is the initial. So now my surgery's goal is very clear. Removal of the necrotic areas, and at the same time, I need to go to the laterally to the infratemporal fossa. This disease has a affinity to spread laterally to the pterygopalatine infratemporal fossa areas, orbit. So I need to have a good paramedian access, not only for the surgery, but for the post-operative surveillance as well. So my first, approach or the work starts with the modified Dankers, the Sternman-Canfield approach to access to the paramedian area, which opens up a gateway to the paramedian skull base. So this Dankers we have discussed n number of times is again the same thing we are going to do. Is simplest of all approaches to the skull base, particularly the paramedian skull base. It opens the gateway. See what I am doing? This is all necrotic. So I am removing this, the mucoperiosteum with this, our preferred tool. This is cobblator. And quickly I will finish this Danker. I know we are, running behind the schedule by half an hour. So I have to finish it in time as well. We have some excellent talks today by our guest speakers on important issues. See this pyriform aperture.
Yeah, nice. You see the edge of the bone, yeah.
Pyriform aperture.
Important to go all the way down to the floor, yeah.
Yes. you have to assess the floor thoroughly for the palatal involvement, which is not uncommon, I would say. And this all tissue can be easily debrided. You can see this all necrotic tissue.
Yeah.
See,
Yes.
all invaded by mucor. One should get used to identifying a mucor after some time. What is normal tissue? What is abnormal involved tissue? What is enhancing? What is non-enhancing? One should get used to. See, this is all mucor. Now,
Will you do a frozen to reconfirm your diagnosis?
yes. That's why I've taken that sample for the fusion. That is the best test. See, we'll get a report in half an hour. So a lot of people talk about the therapy without a certain diagnosis. If you really want a certain diagnosis, it is the clinical history. The endoscopic picture is good enough most of the time to establish the diagnosis. But still, if you want, you can take a sample and send for frozen section in half an hour. You will find the kind of this classical broad accepted right angle branching fungi, which is classical for mucormycosis. So, in this, funny. See, this is the piriform aperture. Now I'm going towards the anterolateral wall, raising this periosteum. Many a time, this subcutaneous tissue is involved. See this branch of the anterior superior alveolar nerves and vessels, which are severed while raising this.
Yeah.
Yes, periosteum. So this is the anterolateral wall. Now, at this point of time, see, in this Danker's approach, you are not supposed to enter into the orbit at the beginning. So our limit is the orbital floor. So we must make at this point of time where the orbital floor is to stay on the safer side. See, this is the anterior wall. I'll do something to it. I can coagulate this to improve my field. At the same time, stiffen this wall so it doesn't collapse easily. See this? Now,
Yeah.
drill. Now, this is our favorite MRA drill now, the newer version of the stylus. Just to make an opening into the maxillary sinus and to define the level of the orbital floor. Simply, see, I am into the maxillary sinus now.
Perfect. Let me show you where we are. See the inside of the maxillary sinus.
Yeah, we can see
Very clearly. Very clearly.
Inside of the maxillary sinus and see the level of the orbital floor. That is what we want to ascertain by means of this opening here.
Yes.
So that we do not enter into the orbit accidentally while making this approach,
Yeah.
So you can reach right up to the level of the orbital floor. There a drill there. Retract. Retract.
How far laterally does one drill, Satish?
Yes, depending upon your need, you can remove the entire anterolateral wall. You can easily go up to the V2, the infraorbital nerve, and now with the the technique described by Paul Casanova, you can transpose the infraorbital nerve and go around even further. You can remove the entire anterolateral posterolateral wall after transposing the infraorbital nerve. So laterally, no limit. Depending upon the need, depending upon your lateral extension required, you can easily remove this, wall up to anywhere you want.
Loma, spatial transposition. You can.
So this is the basic approach. And now I'm thinning this wall so I can easily punch it out. See, I can see my roof there.
Yeah.
Very clearly.
Now give me first debrider. See my level of the orbital floor. Can you see?
Yes, yes.
Much better. Some polypoidal thickening inside the maxillary sinus. Not very important.
That just reactive, right? That's not the disease at all.
Yeah, that is because of blockage. And now, this the only important structure now we are coming across in this approach is the nasolacrimal system. Yes. So now, suction करना बोल रहा है. See this? I can punch out this wall after thinning it and directly reach to the level of the nasolacrimal duct. This is much easier way of,
Faster and efficient. Thin it out and then punch it out.
That is our nasolacrimal duct coming up.
Yeah.
Yep.
So you can punch out this wall. So there are many ways to do the same thing. You can remove by the drill slowly. You can use a Gaussian hammer according to the availability and instruments and how you are used to drill. Sorry.
Remember in the earlier days, Satish used to use a Gaussian hammer.
Yeah, I have tried all. That is much faster, you can say. Little crude, but much faster way of doing that. See the nasolacrimal duct here?
Yeah, yeah.
This one.
Yep.
That inferior turbinate is necrosed.
Yeah, already necrosed. See, your diagnosis most of the time is confirmed by and large by means of nasal endoscopy.
Satish, can you have no crust on the turbinates at all and still have the disease either in the palate or in the orbit?
Yes, it can be.
Seeing endoscopy is
but
like
not so common. Not so common.
Very uncommon, no?
Yeah, see the middle turbinate.
Yeah. So I want to ask the question the other way around. A nasal endoscopy would definitely give you a clue. It cannot be that you miss something.
It is not 100% sensitive. You can say. But majority of the time you get the information from this only.
Because now with
drill
complaints coming.
See, this is my nasolacrimal duct.
Yeah.
What I will do now, see the duct, I want to cut it sharp right at the level of the orbital flap so it doesn't remain there hanging and doesn't get fibrosed. The epiphora is quite disturbing otherwise in the post-operative period.
The bone really gets very hard here, no? Thick and hard.
See the level of the orbital floor. Drilling this bone is the most precise way of, carrying out this step.
It must be emphasized that the cutting of the nasolacrimal duct should be flush with the roof. With the orbital floor.
Five minutes ago.
You don't drill through because you're afraid you'll damage the duct completely. Therefore, you go to the punch.
Yeah, you can thin out the bone and see this.
Yeah, beautiful. Yeah, you can see the groove for the duct.
You can do the way you are comfortable with, you are used to. No big issues. For the, do you? This nasolacrimal duct is formed of 3 bones. More importantly, the frontal process of the maxilla, then the lacrimal bone, and the lacrimal process of the inferior turbinate. So all these constitute this nasolacrimal duct. So this bone has to be thoroughly removed. Debrider. How is the picture?
Good.
Excellent.
Good. Yeah. Look at the level of the orbital floor.
Yeah.
Later. Time spent in this approach actually saves not only time but the overall patient, because this gives you amazing visualization pre and per and post operatively.
A lot of people have a little bit of a reservation. They feel this is an overkill. But I think for Mucor, I think this is the most deserving and appropriate approach.
Yes.
Especially in a pandemic where now you want the post-operative examination to be brief and complete and brief, the other way around.
Ashish, there are so many factors contributing to the so-called high mortality in mucormycosis.
Yeah.
Not a single factor which is responsible. There are so many.
Which actually are preventable or are grossly could be minimized.
Yeah, drill. See my nasolacrimal duct?
Yeah. So I've also ordered the new MR8 Satish coming on Saturday.
Pardon?
Okay. No, I have also ordered this new MR8 this handpiece.
MR8.
Yeah.
Okay.
This drilling is important, one for the NLD and also now to get access to the orbit, no? So this
Yes. Yeah. You have a full access wherever this disease can go.
Has to be flushed. Sometimes
full access. By default, full access for all possible.
Yeah.
See this?
Yes.
Completely flushed and cut. So now there is no obstacle. Drill, debrider. Now there is no obstacle.
Very nice.
See, we have to expose the orbital floor.
Correct. It is
as well as the medial wall completely. I will show you the complete exposure later.
Yeah.
To enter into the orbit and clear it efficiently by endoscope.
Yeah.
And micro debrider will be the key tool for the actual debridement. See, my palate mucosa is healthy. Can you see here?
Yes.
Yes.
See, the maxillary floor mucosa is healthy.
Yeah.
Right.
And I could see on MRI same that palate need not to be removed. That's a very vital information, I would say,
Yes.
get on MRI.
What is the situation of the posterior septum? Any idea?
Posterior septum is probably difficult to appreciate from MRI unless the bilateral mucosa is involved.
Yeah, but visually
becomes avascular. But in such cases with a unilateral disease going up to the orbit, going up to the skull base above, all terminates involved, it is better to remove the posterior part of the septum at least.
Yeah.
So we will thoroughly analyze the septum.
So if there is a crunch only on one side, can you just remove the perichondrium on one side, or it's always best to sacrifice?
Let's see how it turns out to be once you start removing.
Not in this case,
I'm asking. Yeah, if it is thoroughly healthy, we can preserve the opposite side, perichondrium. The wash. So this is the initial picture after the Dankers. Okay?
Yeah. Yesterday, I had a case presenting as a septal abscess, Satish. She turned out to be mucor. I talked to you about her.
Pardon?
Yesterday's case presented as a septal abscess.
Yeah, you told me. You had shown me.
Yeah.
Post-COVID?
Post-COVID, turned out to be mucor. So
wow.
We aspirated, sent it, and
the septum was involved by the mucor. Suction wash.
So what did the MRI show, Ashish?
No, so it was limited disease. It was mainly the septum and actually the anterior sphenoidal wall. So we had to remove all of that.
So this is the gross picture.
Yeah, very nice.
Now I will keep on going behind and remove the middle turbinate, clear the sinuses, and that will open up. See this?
Yeah, already everything dead. Yeah.
All gone. Classical of mucor.
This sequencing of doing the modified Denkers first without doing the FES beforehand, because it prevents the blood from coming into your surgical field. So it's better to go from front to back.
Yeah.
And top to down. Down to up, sorry. The blood doesn't keep trickling in your surgical field.
Denker is boomed to such,
Yeah.
Clearance, surgical clearance in mucor. And post-operative as well.
Much of it in the first wave webinars that you did for angiofibromas. And I think that knowledge is now coming so handy to everybody for the Denkers. People have seen it God knows how many times. The other day, like I said, I think you've probably done more Denkers than Mr. Denker himself. So tell us about the phenopalatine artery, and is there some... Yesterday I spoke to you about it. If it is necrosed, does it indicate that the palate is going to be that much more, or there is
that is the region of the sphenopalatine artery.
Yeah.
That is the area. That is the sphenopalatine area. Sphenopalatine foramen you can see.
Yes.
And this is behind the posterior wall of the maxilla where it is going into pterygopalatine fossa. Now, coming to the ethmoids above, I am still with a 0 degree. See the ethmoids?
Yes.
You saw on MRI, everything was black.
Yes.
If you see anything on the MRI, everything black, get ready for the necrosis.
How often do you find the cribriform plate also involved?
Yes, these days very often.
So what do you do then?
I strip gently the mucosa, staying very gentle to avoid a leak. And if there is remaining, I coagulate that. We have a couple of intracranial extensions also we have operated. Some patients are doing well, some we have lost. So that is I would say the grave prognosis you can think of once the disease spreads to the once it spreads to the CSF circulation, the prognosis is really bad. See now, wash. I will just finish my word with a 0 so that I can change to 70 quickly after that. See, this is superior turbinate.
Yes.
Which is also involved. All has to go.
What is the bare minimum that you have ever done in a case? How early have you had a chance to be to intervene surgically?
Bare minimal surgery.
Yeah. What is the bare minimum that you have ever got a chance to do?
Yeah, the same what I have done so far. This much turbinates and little bit of the septum. That's it.
That's it.
Early cases.
But even there, you would prefer to do a modified Denkers only, no?
Yeah, but my surveillance, because this disease has a propensity to spread laterally. See, in high percent of the cases, the infratemporal fossa and the pterygopalatine fossa are involved. Even everything straight, everything seemingly normal,
Yeah.
The posterior wall of the maxilla and everything looking normal, and yet you find involvement in the posterolateral areas.
Yes.
How does it look in the postoperative surveillance if it's coming back? The bones.
Yeah. Necrosis.
You start getting the crusting again?
Yes, necrosis.
Necrosis. Okay.
Sphenoid sinus.
You see, the posterior wall of the maxilla is looking deceptively normal.
Yes.
That is why most people tend to stop here and hide the disease behind.
And I generally widen the sphenoid in all cases till floor. Towards the floor, so that I don't miss anything inside.
And you said the bone of this sphenoid also can be...
Yeah, because very commonly the floor of the sphenoid is overlooked. It is involved in continuity with the pterygoid process. That's why, remember, in all cases, make sure to open this. I've shown you earlier as well. We don't do this in our regular sinus surgery.
No.
I remember in one of these webinars, you had to drill the floor of the sphenoid.
Yeah, the other day, no, he did. I think he had to drill the climax so much.
So now, let me show you the sphenoid inferiorly.
Yeah.
See the floor of the sphenoid?
Yeah.
Later. And that's a very important area to inspect positively in all these cases. See, the failure in surgery is attributed to many things. The hidden areas which are overlooked. The bony involvement which is overlooked, that is most common. This marrow bone, once invaded by the fungus, has to be drilled away. Otherwise, no amphotericin or anything is going to work. What is it? See right to the floor.
Yeah.
Yes.
This is your pterygoid process. Okay, this is one aspect. This is your pterygopalatine fossa. See this?
Yes.
What do you say, Ashish? Involved or not?
Without the MRI that you read, we would have said no.
Without the MRI, we would have said it's good.
Magic box.
Silly.
Magic box.
It's the mucosa is reading nicely.
See this magic box.
Yeah.
Section karna. Yeah. You can easily open this space.
Yeah.
It
has to be nice, wide, and big for you to get access. Otherwise, yeah. Just you have to everybody mark the level at which he does this.
Okay.
Keep it flush to the inferior orbital wall, no, Satish?
Yeah, we will.
As high up as you can go.
We will. Give me the carisol. हटाने की क्या कर रहे हैं? देख करो. Section. हटा.
Can the look of the periosteum be a reasonable? Yes.
See this?
Yeah, we can see the necrosis. Yeah.
Yep.
That is something important. And in all these patients, this area is very close to the orbital apex. Wash. धार मारो ना. Give me a serious disease.
Yeah.
A small vessel can be
Palatine.
धार मारो. क्या करता है?
Does the look of the periosteum change, Satish, or it's not a reliable?
See this disease?
Yeah.
Yes.
See this all necrotic tissue?
Correct.
And laterally this is inflamed tissue. See this, all inflamed tissue need not to be removed. Only the necrotic components need to be addressed.
Do you mind washing and showing?
Yeah. धीरे चल यार.
The artery.
This is V2.
Yes.
Yeah.
And this is your vessel.
Yeah. Okay. Okay.
See the level difference?
Yeah.
Yes.
Learner clip. So I will apply a clip to the most lateral aspect. Okay?
Yep.
Yeah. And this patient has a typical symptoms of V2, numbness and all that. See, the V2 is involved.
Yes.
And in such patients, most of the time we have to sacrifice this completely. Now see where exactly we are. Just open you to show you how close we are to the orbital apex.
Yeah. Yeah. Moved. Yeah.
That is the apex of the orbit. I will show you the other structures there. Yes. See in the sphenoid sinus, this is your sella.
Yeah.
Here is your carotid artery. Anterior to that is the supraorbital fissure. And just below that is the V2. This is V2.
Yes.
Which is inflamed and involved. And just above that is the supraorbital fissure, the level of the orbital apex.
Yeah.
Involvement of the pterygopalatine fossa is not so uncommon curved. I told you. And the reason is its close proximity to that critical area, Carison.
I think by default, I think it's a good idea to say open the pterygopalatine fossa in
almost all cases.
All cases, yeah.
I will follow it. I will find only the inflamed tissue. And see, after this, behind would be the pterygoid process.
Yeah.
Okay?
Yeah.
एक और देना क्लिप लगानी पूरा. See, this vessel is contributing.
Yeah, yeah. Yes, that's a branch there.
Also there. So these are Karl Storz clips.
Yeah, we got them. Yeah.
This is V2, which is gone by the inflammation.
Yeah.
This.
Yeah.
This is the region of the pterygoid and the beginning of the greater wing of the sphenoid. You have to thoroughly, radically clean this region, you know?
Yeah.
See the bone behind?
Yeah.
This is your median. Give me the drill. After that, I'll take the 70 to go up. See the clearance in this region. And you have to ensure a complete clearance under vision. In the last MRI, I had shown you about the greater wing of the sphenoid.
Yes.
You have to follow this bone. Just about that is the temporal lobe of the brain.
Yeah. Yeah.
See where the foramen rotundum is. This is bad bone, which I am removing. Give me the debrider. See, this disease has a special affinity to involve the maxillary and the sphenoid bone. It can involve the other bones, ethmoid, frontal also, everything. But these is special affinity towards two bones. More and more clearance will lessen the requirement of intensive medical treatment.
The moment you start controlling the sugar levels, does the rate at which this mucor grows, does it reduce?
Definitely, but depends upon the hypoxic areas, you know. If you don't debride adequately, that gives the best, I would say, hospitable environment for the mucor to grow in dead acidotic hypoxic areas. So देखो calculator दे. See this marrow bone.
Yeah.
This is Satish?
Yes, yes.
I would drill it out for sure.
It has to be, yeah, dealt with thoroughly.
This you spotted on the MRI?
Yes. That's why overlooking the involved areas without a good radiology see the video now.
Yeah.
All the way.
So if this would have been left behind, I'm imagining I would have left this behind because I would have not been able to see it. The patient would have not recovered at all.
Yeah, how would this area be treated?
Please say it again on radiology. How does one identify this?
Yeah.
No, please say it again for me to...
Yeah, I will show you. Yeah. See the plate of bone coming now?
Yeah, nice.
The reddish bone coming now?
Yeah.
See this plate of bone?
Yes. Smooth texture, yeah, you can see. You're drilling away.
This is my, median nerve is a guide to the carotid.
Yeah.
The best guide to the foramen lacerum carotid. See the clean bone now. Absolute clean bone now. See, this is our artery, this is a pterygobaltan fossa. That's the carotid here, median nerve here, carotid would be here, sella here, and then your orbital apex is here. Okay?
Yes.
Wash. Now I will change to 70 degree. To go up, we all know the disease was going up, and with this only we will enter into the orbit to clear the orbit completely.
Which is the best area to always enter?
Best?
Which is the best location to enter the orbit?
From the medial wall and inferior wall. I will show you.
Where are you farthest from the muscles?
See, this is the area of the orbital apex there. See the septum?
Yes, yes. After the last webinar, you pointed out, we started looking. We stopped using adrenaline packs now. We are only decongesting the nose with Otrivin.
Yeah.
Because to get the realistic, we don't want vasoconstriction and things to start looking pale. That's one thing we've changed for Mucor. Then front to back and down to up. That's
serious septum involved.
Yeah.
That's why I told you in such extensive involvements of the turbinates and the skull base, we must remove at least the posterior part of the septum. If you overlook this, this is going to come back. For sure. We have seen in our cases, earlier cases where we, stayed conservative, left the septum, and then afterwards we had to revise them. So this posterior most part of the septum is the one which we are going to revise. See the skull base involvement?
Yes.
See the colors all.
Oh my goodness. See the frontal bone involvement. See the bone.
Yeah.
Actually has a purplish hue, I think, this necrotis.
See, this entire bone is gone. I told you it is going to the ethmoidal roof. You can see.
Yeah, very clearly.
The anti-ethmoidal well.
That's the posterior anti-ethmoidal artery, you can say.
Does this get thrombosed also sometimes?
Pardon?
Does the anti-ethmoidal get thrombosed with Mucor?
Bone?
No, the
anti-ethmoidal artery.
Yeah. Yeah, I don't think any circulation in this. Last time also I showed you the thrombose.
Yeah, you showed, yes.
Yeah.
See with the 70-degree hidden areas, the uppermost part of the septum was involved. One can easily miss.
Always interesting to look from down up.
So, do you remove the entire bony septum?
Not really. It's not needed most of the time.
Okay.
But yesterday with my septal abscess, I had to, Satish.
Yeah. I'm not saying always, but most of the time you don't need to. See this bone?
Yeah.
I told you what we are going to find inside the orbit. I told you from MRI.
Yep.
And I will uncover that very soon.
Shows the best strategy of uncovering the orbit and how to approach the orbit in the most elegant way.
See, before I open the orbit, I need to address this bone. Otherwise, my orbital content will fall in between.
Yes, and then it will block.
And will create problem. Okay?
Yeah.
So I had to address this.
To finish your frontal and the complete clearance before you.
Yeah, this frontal part of the one. Somebody was asking if frontal bone is involved sometime. See the example. So I'm back with 0 degree.
No need to rush, but just letting you know it's 4 o'clock.
Yes. Won't take long, Ashish.
Yeah, I know. Once you open it, it's not going to fall. Then we also have Satish now then talking about the microbiology, and we have two top microbiologists from the country, Dr. Sonal, who's going to present. She's quite a maverick. She's going to speak about the RT-PCR for Mucor and many other things that can be done. And the other person is from Canada. His name is Matt. He's the director of an institute of mycology in Canada, and they have got one or two cases. I forget. They definitely have one that I know, and he will present his work. He's quite renowned all over the world for his work on fungus. And we will, of course, with the
actually, I'm reaching to that frontal bone.
Huh? Yeah.
I'm reaching to that frontal bone, which is involved. Like we do Lothrops.
You're removing the beak now.
Visibly, it's impossible to tell it is diseased.
Pardon?
Visibly, it is impossible to tell. I mean, I don't think we have enough visual memory of a diseased bone of mucor.
I can't hear you. Ashish said something?
Yeah, Ashish said that visually it's very difficult to make out whether it's disease, this part.
The bone, the quality of bone.
Yeah.
See, that's why one has to get used to identifying what is good, what is bad. It comes. See, I changed to 0 degree and debrided that frontal bone. Now see the area.
Yeah.
Yes.
Healthy?
Yeah. Yeah. We can see the anti-ethmoidal in the center of the, correct.
See the frontal bone area that was bad. I have debrided and now it looks healthy.
The idea of this webinar is really to raise your bar of excellence. You know, you have to have these visual memories in you when you are dealing with your surgeries, when you're dealing with your patient. This is what we have to aim for. When he says complete, and he stresses on that word complete so much, I think just doing a namesake face or opening the maxillary on, I think those are jokes for mucor. Probably the mucor fungus is laughing.
See now the entire skull base clearance.
Yeah, Satish, beautiful.
Complete entire skull base you can see now.
Yes.
This part of the septum I know has to be removed, as I already mentioned.
But let's go to the orbit,
Yes, now we go to the orbit, 70.
And again, the look and status of the lamina should not be mistaken to be assuming that the orbit is good, right?
Yes.
Yeah.
Now, first of all, I'll open up the floor. Ashish?
Yeah.
See with my chisel light. With my chisel, first of all, I will open up the floor.
Okay. Now tell me that if I say this fat looks good, I have made a blunder, right? Because I did not read the MRI properly.
Yeah, so MRI guides you everything.
Yeah. So otherwise, at this point, one would think the fat looks nice and healthy.
Yeah.
And
see the periorbita?
Yeah.
All necrosed.
Yes.
Absolute white.
Pale, absolutely. So which is the point you'll incise the periorbita?
The debrider can start from anywhere, but mostly posteriorly.
Now he is very clear because his MR reading and what he showed.
Yeah.
No hesitation in his head. He exactly knows. So now he can be very aggressive. I mean, the patient is blind anyway, so on that side.
Now, see, I am. First, I am debriding the periorbita.
Yeah.
See the necrotic tissue.
Correct.
Let me show you. See the necrotic tissue.
Yes, yes, yes.
We'll show you. For 60 there. For 40 there. See the necrotic tissue.
Yes.
All necrosis inside the orbit. See, this is mucor.
Yeah.
Yeah.
See the necrosis.
Yes, Satish, yes.
All rotten.
I'm wondering whether Oak sir is back.
I have to see.
Now this Satish, you go by the feel. No, the tip is feeling the orbital
Yes.
walls.
Yes.
Yeah.
See, I need not to remove the
Muscles. Yeah.
anything which is,
Which is
healthy, vascular.
Now there it all looks nice.
Yeah. See this now?
Yeah.
What is there?
Oh God, yeah. Okay.
All gone. See, you can. That is your optic now. That is your globe.
Yeah.
Yes. See the necrotic areas here and there. The best part about this is what you do endoscopically. It heals up so fast. It doesn't give a visible depression in the eye from outside much. See the floor area. See the floor?
Yeah. Super.
Everything?
Yeah.
See this necrotic area.
You had cases with the orbit and the palate being involved?
Pardon? Yeah, many cases. Vocal cord retract.
Let me take this opportunity to welcome Dr. Raj Bhayani. He just joined us from the United States. He is the president of the Federation of Indian Physicians Association. Welcome, sir.
Hi, Raj. Hi.
See this necrotic region.
Unmute.
See this necrotic region.
Yes. Let's see. Raj, you have to unmute.
And it's very kind of him to be fully up and about at 6:45 in the morning in New York.
Beautiful, Satish. Yeah.
Wow.
Oh, some more. This is going all around the optic now.
You know, all around.
Yes, all around.
See here?
Yes, yes.
And from here, see there?
Yeah, yeah.
See there?
Yes.
All everything healthy?
Yeah.
So we removed only necrotic regions. See this necrosis?
Yes, this, I was about to ask you that, yeah.
That's your eyeball.
Yes, that's a globe.
You seen that being necrosed also?
You know, every nook and corner of the orbit can be visualized. See that?
Yeah.
Optic nerve, eyeball, the muscles.
Dinesh?
From this side as well.
Please unmute Raj. Raj Biyani, he's just joined from New York. Hi, Seti, back.
Welcome back, Seti.
Please unmute Dr. Raj. Dinesh, are you there?
I'll tell him.
Ashish, we are finishing soon.
Yes, yes, I know. So Sonal, I can see Sonal is also there. Dinesh, also unmute Dr. Sonal. And I don't know whether, can they see Dr. Matthews? He's going to join from...
See now the contour of the eyeball, orbit, everything will remain.
Yes,
I mean maintained.
So there's no cosmetic deformity from the outside.
Yes, debrider. See the eye from inside. Get fibrosed and doesn't give any problem, and it heals so fast. As compared to the other areas, this globe heals faster.
Achha.
The last thing left to us is the septum.
Septum, yeah. Sonal, are you there? Yeah. So Satish, we want you to listen to the microbial talk intently and discuss it, because I don't think anybody else has so much knowledge.
Only 5 minutes. I need only 5 minutes.
No, take your time. Take your time. No, what I mean is when Sonal is talking.
We would love to listen to her.
Hi Sonal, hi. Dinesh has not unmuted. Ashim, have you told them? Have you told Dinesh?
Yeah.
Both, Dr. Sonal also. Dr. Sonal loves to watch surgery. So she's been...
Microbiologist.
Anything that she cannot see under the microscope, she hates. For the record, she doesn't eat yogurt because she has microscopic vision.
See, Ashish, this is our bone.
Yeah.
Yes, so they have unmuted me, Ashish.
Ashim. Hi, Raj. Hi. Thanks. So now we can hear your voice besides seeing you.
Yes, that's
Ashim,
right.
Go ahead and introduce Ashim. Is
Look at the globe again.
Brilliant, Satish. Super. Absolutely top.
You can see this area.
Where is that anti-rage model?
That area. Yeah. Inside the globe, optic nerve, and more importantly, no necrotic tissue is left behind. That is the goal.
In this case, where would you look for if you were to look for when you do the surveillance post-op?
Where do we?
Where would you pay attention in such a case when the debridement is so thorough?
Yeah, around the optic nerve. All corners of the orbit, particularly lateral to the optic nerve.
And you would, if at all it was to come back, or if it was to show itself, it would start showing as a crust in that region?
Not really. See, if you leave anything behind, the things will remain same. It will keep increasing. Now, this is the picture after this work. And now I will come with 0 degree again to remove the part of the septum. Only the posterior part and upper part of the septum, which is more likely to be involved. In this case, we have seen the frank involvement superiorly. Yeah. See the posterior and superior part. This is the most common site which is overlooked, or the most common site for the gout section, for the residual, disease.
And
this is septum. This is septum.
Yes. Picture of the mucor in this current times, no? More and more patients with the septum are, after you pointed out in the last webinar, we find it now in almost 80% of the cases.
Yeah. Anterior part is almost always spared.
Yeah. I think
except in more
the middle turbinate, that's where I believe the
whatever contiguous to the middle turbinate, and obviously the areas which have got necrose due to the thrombosis of the anterior ethmoidal vessel.
Yes. Vascularity.
Yeah. Even the posterior nasal nerve and vessels are often involved in this.
No. I can simply remove. Let me show you other tool. Scissors.
So in this case, I'm going to proposing to keep the perichondrium on the other side intact. The periosteum.
But since the upper part was frankly involved, I am not keeping.
I get it.
See this?
Yeah.
It is flimsy, yeah.
Rider.
What was that very high-tech instrument you used some time back?
See, this is the simplest area to deal with. Not to leave any chance of disease in this region. This is relatively one of the simplest area.
Yes. But often neglected.
Yes, that's what. See the opposite turbinates absolutely normal.
Yes.
This part of the septum is really looking bad. That's the last thing. Wash this. धीरे-धीरे डाल दार बना. Oh.
Satish, I just got a news. Central government invokes Epidemic Act for Mucor.
Which government?
The central government invokes Epidemic Diseases Act 1897 for Mucor.
Our government yesterday has already imposed.
Achha.
Rajasthan government imposed yesterday. I think it is good for
people. The people in the administration govern, and the type of technology, the type of consumables that are required, the coblator wand, the debrider blades. It's a very expensive affair to do a good job. I mean, you need technology, you need disposable. I think it's time they took notice that to do such a great and complete clearance, there is so much.
This is a matter of life and death.
Life and death, and no, what I'm saying is, in terms of what the ENT goes through or the investment they go through, this cannot be.
So it requires a lot of tools.
lot
good
of
camera,
lot of cost.
good
It's not about nobody thinks
micro
of
debrider, carburetor, lot of disposable vents, high-speed drill.
Yes. And without
sometime navigation system for deep, extensive work, particularly when you deal with carotid artery, cavernous sinus, skull base.
It's a very, very expensive infrastructure and per patient cost.
Yes.
Satish,
without all that is a compromise, big compromise.
A big compromise.
See now, I remove the part of the rostrum.
Yes.
Yeah.
See, thoroughly visualize this. This area should not be overlooked. See the sphenoid floor.
Yes, yes. And I think it's a good idea to make a rule that if you have to remove the posterior part of the septum, it's best to go ahead and
always do that. It is always good.
Yeah.
And look at the sphenoid floor thoroughly.
Yeah.
It is one area which can be easily ignored. See now the panoramic view. Everywhere vascularity.
Yeah.
Yep.
Remember when we started?
It needs to bleed well.
Yes. Everywhere. We want this. See the value of dankers.
Yeah.
You can go inside the orbit and do anything you want to. If you leave necrotic tissues in the orbit, the patient is going to die soon as it spreads to the skull base very fast. I mean, intracranial space. Tablet.
Can you define that fast? Is a matter of days?
Yeah. Orbital apex is a port of entry to the intracranial space. We can, it easily invades the cavernous sinus in no time. See, without this much of clearance, even if you have ample of liposomal amphotericin, are not going to work.
Yeah. You will keep flooding
they have to penetrate the tissues to be effective.
Yeah.
And for that, the tissue should be vascular.
Typically, your patients don't need more than 7 or 10 days when the debridement is so good.
Yeah, I rarely give beyond 7 days. Sometimes I don't feel like giving after 4 or 5 days, but this disease is so dreaded.
But then your guiding factor, what's the end point of your decision? The CRP?
CRP, clinical, overall endoscopic picture.
I was asking, is there a role for any microbiological endpoint? I mean, the endpoint, can you take a swab again from somewhere and decide?
Should you recommend a punch biopsy or swab in the immediate post-op period, maybe after a week, days or so?
You have to direct by some means, meaning some clue. From a seemingly normal mucosa, here and there punching is not going to help you. If you have any suspicion anywhere, of course, you don't have to think twice. Since the skull base was involved in this, see that?
Yeah.
I'm very conscious about, I am with 70 now, with the upper part. So this upper part is a hidden area, This is the roof of the nose, I would say. And see how completely it is addressed now.
Super. What is your view on putting amphotericin gel in your pack?
Yes, we always now.
Yeah.
This entire bed will be covered with the amphotericin gel.
And do you repeat that process on an alternate day basis or something? Repack?
Yeah. Post-operatively, if you have excessive crusting is another thing. Should be a suspicion for some, mucor growing below.
Okay.
That is how it presents.
Would you recommend using hyalase gel for better tissue penetration of the topical amphotericin along with it?
Not really, boss. Never done. But this gel also is a very good formulation.
Yeah.
We'll apply a pack, but you know what happens in the critical areas, you can apply directly. Gel.
Guys, use hyperbaric oxygen by any chance?
Syringe में लेके. I will show you that gel in the syringe with a curved sucker or anything you can apply anywhere.
Raj is asking about a role of hyperbaric oxygen in.
Not really. There are some publications, but it's not supported well yet.
Raj,
see this skull base.
Yeah.
What I can do now at this skull base, just to show you how you can, apply to the critical area. See this?
Yeah.
See, this is my gel. With the curved
Very
sucker.
nice and thoroughly done.
See now
Satish,
at the orbital apex, I'm pushing at the orbital apex.
Yes.
So all those areas, critical areas, there could be a disease was at a high load, you can apply this gel. See this?
Yeah.
Let it remain in contact for a day or two. Give me 0 degree now. Orla na? Orla. See how easily you can apply. So this is liposomal amphotericin B gel again. See, this liposomes are.
I think there's a gauze piece there.
Arranged in such a way on both sides of the amphotericin that it penetrates the lipid wall of the fungus well. So the penetration of the liposomal amphotericin as compared to the other combination, other formulations is 20 times. See the liposomal amphotericin B gel?
Yeah, we can see.
Excellent.
So it sticks well. So we will leave it this pack for a day or two to all raw areas where the fungus was suspected.
I have exhausted all my ways of saying you are the greatest and the bestest.
See that?
Outstanding, brother.
Bada mota de. Now see the lower part. Leave this in, contact, is just section there. With the key areas, live in contact for a day or two. The crusting will be minimal when you remove, see after a day or two. अरे सब कुछ है बुद्धि छोड़ सब कुछ लेके आना और तू ला दे वीरेंद्र ला दो.
So for people who don't know, Satish is probably doing about 15 to 20 cases every day. He has 52. The last that I spoke, 52. How many patients admitted, Satish?
Pardon?
How many patients admitted? You're doing about 10 to 15 cases, 20 cases per day.
Right now, around 50 plus.
50 plus people are admitted. Those who are operated, he has actually rented a hotel across the street, and there are 50 rooms that he's taken there. People are getting their IV amphotericin there. So there is simply no place for patients to be accommodated there. So probably the largest that anywhere in the world that this work is happening. They are very lucky to get all the ready-made wisdom and knowledge and expertise from this.
How is the situation of amphotericin availability now?
Zero.
It is difficult. We are getting, but not
it's not predictable.
as much as required.
That one day dose will come, not come, next day it will come or not. Hopefully in another week's time, Raj, things will be
Yeah, it will be solved. The crisis will be resolved in a week's time, most likely.
This is Raj formally. We have to tell that they probably sent thousands and thousands of oxygen concentrators when Delhi was choking, and Raj was spearheading this help coming from the US, from the American community at large. I'm not sure it was restricted.
See the final picture, and now we'll put a pack.
Yeah. So pack is just aerosol, no?
Brilliant.
Thank you. Thank you for your attention.
Master, thank you so much.
That is a very well job done.
To watch you operate, boss.
Amazing work. Very nice.
Ashish, last thing, there was a question.
Yeah.
To show on are you getting the MRI?
Yes, we're getting the MRI.
From someone online, that how do you differentiate the invasive and non-invasive sinusitis? Only on MRI you can easily differentiate. Look at this T2 weighted image in any MRI. See, this is the inflammation in the sinus.
Yeah.
And a non-invasive sinusitis where the sinus walls are intact, you will not find any sort of inflammation going out to the outside of the sinuses to any surrounding area. See the inflammation in the surrounding regions. See this?
Yeah.
With the bony walls intact. Completely intact bony walls and the inflammation going to the surrounding is classical for invasive fungus.
Okay.
You pick up the MRI, see the axial sections, and see all around the sinuses. If it is non-invasive sinusitis, there will be no inflammation outside the sinuses at all. With invasive sinusitis, in spite of the intact sinus walls, you will find inflammation beyond the intact wall. That is classical of invasive sinusitis. Thank you. Now you can carry on.
Lovely. So now we have three of our eminent speakers, the guests today. Raj, of course, is there, and Ashim will introduce him suitably. I was completing this that Raj has organized thousands and thousands of oxygen concentrators, is what I know of. I don't know what other assistance these our Indian doctors in the US have done. So thank you, Raj, from all of us here for such a timely thing. And Mucor is also one of the areas where we'll collaborate with you if and when the time and need comes. Before I let Ashim, let me say, Matthews has also joined from Canada. Matthews, hi. I'm not sure since how long you've been there and how much surgery you watched. And we will speak about you in a short time. Yeah?
Hello.
Thanks. Okay,
Thank you.
Go ahead with Raj and then I'll introduce Sonal.
Welcome, Dr. Rajendra Bhayani. Thank you very much for joining us. I know you've broken your sleep to be with us here. It's about 6:45 in New York just now. Dr. Bhayani is a renowned medical professional, and he's also not only is he an ENT surgeon, but he's also trained in neurosurgery and facial plastic and microvascular surgery. So I don't know what aspect you left to the neurosurgeon and the plastic surgeons anymore, but that's really amazing. And he has done a lot of work of improving the healthcare field, and he has won the American Triological Society Award. And if I go to enumerate all of his achievements, I think it will be the end of the webinar. But suffice it to say that we are very grateful to have him here. And he is so close to the Indian community of physicians in the United States. And he's also reaching out so professionally and personally to the Indian community back home, to doing his bit to making sure that he and his colleagues are serving our country, especially during this time of need. He's got so many other awards like the Bharat Gaurav Puraskar, Delhi Ratan Award, Asian American Heritage Award, so on and so forth, the Congressional Award, Achievement Award, and also he is one of the most influential leaders in the Indian community in the United States, and he's recognized as such. So thank you very much, Dr. Rajendra, and thank you for joining us here.
Thank you, Ashish and Ashim, for inviting me here. It's an honor to join you all. This is amazing work which you all are doing there, because things are very, very difficult. And in spite of the enormity of work and resources limitations, the work you are doing is unbelievable and unparalleled in any other country in the world. And this mucormycosis actually has affected India so much. It's kind of mind-blowing and makes us really wonder why it should be so high in India as compared to the rest of the world. Because during the height of pandemic, even in the USA, we hardly saw any patients. So I guess we need to carefully analyze, and probably you guys can, if you discussed earlier, I would love to know why is it so high in India as compared to rest of the world. And thank you. What we're doing from here is whatever way we can, because when we see so much difficulty and so much distress happening, we just can't sit here and watch and be just sympathize in thoughts, but we had to take some action to help our motherland. And with that, we reached out to several charitable organizations in USA and in India, and then sent ventilators and concentrators and pulse oximeters and all these supplies. Along with, we also pushed with the government to send remdesivir. In fact, the Indian embassy in DC is very closely working with us to make sure the amphotericin is coming. Right now, everything which Gilead makes is coming to India. Actually, I was about to get some doses, but then suddenly government came and said they're taking everything, because Mylan Pharmaceutical is very close to us, and also Cipla. Both the vice chairman, I talk to them every other day to see how we can get the medications. And individual basis, I have given a few patients the tocilizumab. Also, if any one of you need on personalized basis, because of government restriction, I have not been able to give in bulk, but certain patients we have been able to give as a behind the scene as a charity from the stocks they have. We also have telehealth platform, and that is also picking up. Now we have joined Ekal Vidyalaya. So Ekal Vidyalaya has 100,000 schools in rural areas in India. So the Federation of Indian Physician Association, Ekal Vidyalaya, will have what do we call as the Community Isolation Centers, CICs. And we're going to send them pulse ox and thermometers and blood pressure monitors along with some basic kit. So at least if there is a isolation to be done in those schools which are in the rural areas, can be achieved. And in case if you have any specific way we can help you from here, you let us know. So this is all we've been doing. And thank you for this opportunity to interact with you. Yes, I think that's
Thank you. Thank you so much. We know that you are there. And for amphotericin, if at all, we know you're very, very close to our Prime Minister Modi. And if we need you to whisper in his ears, we are going to use your good offices with the big man. Thank you so much. Thank you for being here.
Great work, great. So why, just Ashish, just 30 seconds, why is it so common in India than other places? Any idea?
Two things, I think. One is the indiscriminate use of high dose of steroids.
COVID treating doctors are on steroids about steroids. That is how it is. I think that is one of the establishable and a reversible thing. We don't know whether COVID is doing something, but right now the Indian doctors were really on steroids and using it for prevention of the cytokine storm and things like that. So we've grossly gone wrong there, and that's been acknowledged in public by the government. That's getting reversed. Even as we speak, there are directives from the government to stop that indiscriminate or, now on the hindsight, an indiscriminate use of steroids. That we believe in the next 4 to 6 weeks will show results, and the number of mucors will come down. Not just steroids, but bringing in a good glycemic control. Maintaining the blood sugars now from day 1 to below 180 is what has been the guideline now. And I believe that will also, because COVID-induced hyperglycemia also needs to be controlled. So sugar control at 180 and below, I think that will eliminate mucor or minimize mucor. Unless the COVID virus is doing something else.
No, now there is a talk about the Indian variant of the COVID virus, the Indian mutant, that is particularly targeting the endothelium even more than the original virus. And that could also be contributing, because both mucor hits the endothelium or the vascular endothelium, so as the COVID virus. So there might be a synergistic effect. So people are talking of better thromboembolic control better anticoagulation for the longer period.
Can we go to Sonal, if you don't mind? Can we have, she's going to give a talk and then Matthew is going to give a talk.
Absolutely. Thank you so much. Appreciate all you all.
Thanks, Raj. Thanks. Sonal, welcome. Hi. You can unmute yourself. Sonal is an eminent microbiologist, one of the rare kind. She's a medical director and founder of an infection lab. It's the first and the only specialized infectious testing lab in India for the last 2 years, because she looks too young now, but since last 2005 or 6, she's been at it. Very, very passionate about her work, and everything else that follows is simply her ability to scale things up. So she's an entrepreneur in her own right, made this infection lab, not gone public yet, keeping it yet within her zone of influence, but growing very, very rapidly and without compromising on quality. She was among the first few lesser known or a non-chain lab to be given the RT-PCR testing, among the first ones, besides the big group. That speaks of the quality. And besides that, he has providing services to clinicians in the field of infectious disease testing. Her areas of interest being tuberculosis, mycology, syndromic panel testing, and other molecular biology tests related to infectious disease management. Currently recognized as one of the most experienced personnel in India in this domain. And she has and she would have won many of beauty contests, but just because she did not participate, she's probably not won them. Sonal, thank you for coming, and please enlighten us about the microbiology in the context of Mucor. How is it that we can collaborate? How is it that together we can help our patient the best possible and the fastest possible way? Go ahead, Sonal.
Yeah, thank you so much, Dr. Ashish, for a very elaborate introduction. At the onset, I would like to thank you for making me a part of your community. After very long years, have I ever seen a surgery? Because microbiologist and surgery is two ends. Here, I would like to take a chance to introduce many more new things which are in the microbiology as regards to mucormycosis. So, if you don't mind, I'll just start my screen share. Yes. Yeah. So it says holistic approach towards diagnosis, because the title itself would say that maybe it's not all. The KOH mount is not all that is there in mucormycosis. There are not many newer things which we can explore during these inspections. Now, mucorales has been a very big group of fungus which causes mucormycosis. So it is not just mucor, it is a big group. So there will be almost 77 species of mucor, which causes mucorales, which causes mucormycosis. Now, just to add on what Dr. Raj Bhayani had asked the question, that why is it so that mucormycosis is so much prevalent in India and not in other countries? I had a small data regarding the amount of cases of mucor in US and Europe. It was up to 0.01 to 0.02 cases per lakh population. Whereas in India, that statistics is 14 per lakh. And this is non-COVID scenario. So maybe the weather conditions in India is such which allows mucor to be there in the dust particles a lot. And that could be associated with large number of cases. Of course, with predominant diabetes capital, India being the diabetic capital, and it is usually seen in diabetic hematological malignancies and trauma. And now with COVID, everything is coming to the picture. So if we just go quickly onto the laboratory diagnosis of any invasive fungal infection, there is a conventional way of looking at it. So it would include your microscopy and culture, which everyone knows about. So I'll go a little details about these procedures. When we talk of fungal stains, today when we talk to ENT surgeons, they usually end up talking only about KOH mounts, right? So KOH mount is one of those tests. We also have fluorescent microscopy, which is much more sensitive than the KOH mount, because as you see in the picture, you can see these hyphae, but these are very it needs a proper observer-dependent test. It is KOH. So when you have to observe a KOH, you also have to see whether it is a filamentous fungi. What you would see is a broad septate hyphae, broad aseptate hyphae, which usually represents the mucoral species on whole. It will not tell it is only which mucor species, right? This is highly observer dependent. My take on this is KOH should be used strictly as a screening test and never as a confirmatory test, because when it will come to medical legal cases, it will when it will come to medical legal cases, it will be a trouble, because you will need some solid foundation of calling it as a mucor infection. So that is wherein your cultures come into picture. Now, when it comes to culture, fungal culture is a mandatory as a confirmatory test. So any sample picked up, say be it a crust or a biopsy or anything, has to go in for a fungal piece culture along with the KOH mount. Now, mucorales are very easy to grow. They grow very quickly within 24 to 48 hours at normal temperatures. And fungal culture will have advantage of you being able to speciate this fungus, right? Major concern would also be that if you mince the tissue too much, it doesn't grow. So there is the sensitivity of cultures is usually 50%. Now, where does culture play a role? I will just put in two cases where we found that doing fungal culture helps. Now, there's case number one, that is a 24-year-old male who is post-COVID, and he develops nasal sinusitis. Post sinusitis on the endoscopy, it doesn't have black scarring or anything like this, which is typical of mucorals. And he is being treated at home, not given any steroids. He's a non-diabetic young boy. Now, this sample is sent for a KOH and culture. The KOH shows hyphae, fungal elements is seen, but it is not very evident. You can see a very rare fungal hyphae there. And the ENT surgeon is a little tensed because he needs to take a decision whether to go in for a surgery for this patient. Now, when we just waited for a day's time, the culture grew mucor on the plate. Now, this gives a confirmatory diagnosis to help the surgeon take the call regarding the debridement, because as you all know, debridement was the first step towards management of the mucormycosis. So this is the first case. The second case is about a 53-year-old lady, again a post-COVID case. She also had features of sinusitis. On endoscopic feature, there was endoscopic. You could see a scar-like thing, and that sample is sent to the laboratory. We look under the KOH; it shows filamentous fungi. Right. On culture, it is growing aspergillus. Right. Now, though people are talking about mucormycosis, it is very essential to understand that out of the samples that we have tested more than 30 to 40 samples in last 15 days. Almost 10% of those samples are not mucor. So why is it so important? Because the treatment protocol for mucor and for invasive aspergillosis is different. For mucor, you would try and prefer amphotericin B or posaconazole, whereas the drug of treatment for invasive aspergillosis will be voriconazole. So that's the importance of going in for fungal cultures. Now, when it comes to identification, there conventional ways I would not like to talk, because those are very raw methods of doing identification. They would just grow it on a culture medium and look it microscopically and give the identification. Now we have much better things to do. Now there is something called MALDI-TOF. Now MALDI-TOF is a equipment. What it does is it ionizes the proteins using a matrix, and depending on the time of flight of molecular weight of these proteins, you can exactly identify which mucor species it is. Now, what you need is a very good library of information when you're using MALDI-TOF, such as Bruker MALDI-TOF is one of the biggest library for filamentous fungi. Now, the best part of MALDI-TOF is time to identification is as low as 45 seconds. Now, as against if you go in for a conventional way, it will take 7 to 10 days. The second method is gene sequencing, which was till now considered to be the gold standard. It is again sequencing based on the ITS region of the mucor. It needs again a database sequence, but the problem is here you need a batch of tests. So you will need at least 10 mucor species grown to do it, and it would take around 7 days time for the reporting. Now, in today's time, what is more important is the quick results. Now, that is what is coming with Malditov. Now, why do you need identification? You removed all the tissue which was there, and do you really require to understand why to identify? Now, let's see at the study. The most common mucor species which causes rhinocerebral mucormycosis is Rhizopus mucor. Then less common is Rhizomucor, Cunninghamella, Mycoclidus, and the least is Acynomucor elegans. Right. Now, all these species, why should we know that this is the species? Because the most thing is all these species respond differently with different antifungal agents. So it is not all the species respond to amphotericin. There are species which respond better to posaconazole than to amphotericin B. And that is the reason identification becomes a mainstay when it comes to laboratory management or evaluation of the patient. Now, just identification, we also have drug sensitivity testing. Now, are we thinking that all this mucor which is coming up and with the amount of amphotericin B that is being used, there would be no drug resistance? It is not so. Drug resistance in mucormycosis is already being established in 2017. So this is by the old papers, it says there is certain amount of drug resistance towards amphotericin already there. So how do we do this antifungal testing? It is done by this MIC method, that is a microprod dilution. It takes only 24 to 48 hours to give a drug sensitivity report post a culture. Now, it is important to track amphotericin B drug resistance because maybe over next 15 to 20 days, it may start developing drug resistance. And that is where we have to be very careful. Now, as far as I know, there are only 3 drugs which can be used today. That is amphotericin B, posaconazole, and isavuconazole. Now, only 3 drugs, out of which ampho B is most active on all isolates except for these 2 species. Now, that is why I had referred to it, that you need to speciate to know which fungi it is. Now, we work very closely with most of the hematology malignancy cases and post-transplant cases. And from that experiences, most of these surgeons, the oncologists and the bone marrow transplant surgeons, they always speciate any fungus so as to understand the drug resistance pattern. Though I understand the physician will take care of these, still a word on drug resistance. Posaconazole has a good activity against Cunninghamella. So if you have this species, it is better to start posa instead of amphotericin B. Voriconazole doesn't have any activity. And there is one more drug called as terbinafine, which has shown good activity against Rhizopus, which is the most common Indian isolate that is there. Now, in this scenario where you have only 3 antifungals, there are no new antifungals in line. There are no echinocandins which work against this. And you have only few azoles like posaconazole and the newer drug, which is having some activity against mucor. It is very like the ENT faculty which is there. It is very nice if you can keep a track on the drug resistance pattern also along with the debridement surgeries. Now let's go at the newer approach. Now you have in newer approach, you have biomarkers and you have molecular tests. Now most of the biomarkers do not work. They are not they are not active in mucor, so we will not consider it for now. Let's come to the molecular test. Now this is a slide which I used to always put in saying that PCR is the future. But today, in last 1 year, PCR has become the reality of today with it gaining so much of importance during the COVID times. Now, even for mucor, you have PCRs available, which are being already validated. These are CE-IVD approved PCRs. Now, what do these PCRs target? They usually target the ITS region of the fungus. and it would cover all the species. So when you call this mucor, it is a pan Mucormycetes PCR, which will cover Rhizopus, mucor, Cunningham, all the species all together. What is the sample that you can use? You can use biopsies, either fresh or frozen samples. You can use paraffin embedded blocks, which you send for histopath, bronchial lavages for pulmonary infections, and also serum samples. I'll elaborate a little bit on the other specimens. Now, yes. Now, what is the sensitivity of this? The sensitivity is as low as 2 copies per microliter. That means even if you find 2 filaments of mucor in a specimen, this PCR is going to come positive. So it becomes far more sensitive than most of these microscopic methods. Now, this is a study done by, it's from a Journal of Fungi in 2019, which says mucorales PCR have been performed on fresh and frozen tissue samples and on the paraffin samples from the affected site post adequate pre-processing. Both these samples showed good results. However, PCR results are better with fresh samples with a sensitivity of 97% to 100%. So I think there is nothing more than 97 to 100% which can be given for any kind of a testing. Right. Now, PCR from blood sample, a possibility. Now, where are we going towards? Now, we can do, of course, PCRs on the tissues that are being debrided and do a full range of testing to go up to the drug sensitivity testing. But this is an experience shared from hematological malignancies. So in hematological patients, it has been studied that these PCRs are now recognized as a non-invasive tool. So you don't have to go take a punch biopsy or a nasal biopsy or the debridement tissue to put in the diagnosis of mucormycosis. It can be done with blood samples. Now, the study says as early as 8 days before the mycological diagnosis, that is when the KOH comes positive, or 3 days before imaging, that is your MRIs or CT scans, you can get mucor in the blood. And that is our target, to pick up mucor before it gets really invasive. As you all know, it is angioinvasive, so it invades all the blood vessels, through the blood vessels. So that is the major reason why we should look at serum samples for early diagnosis of mucormycosis, especially post-COVID. Now, these have a very fast turnaround time, specific, and cost is much acceptable. Now, false positive is very rare because the sensitivity is almost 97 to 100%. Now, a short word on fungal biomarkers, because like we said in our study, there is 10% of cases which are non-mucor. These are other fungal. So if you have to quickly rule out if there is any other fungi which is circulating, you should do a beta-D-glucan or a BDG test, which will quickly tell you whether it is an aspergillus infection or any other infections which are combined. So if I have to share a short experience of our last 20 samples, which we did with the KOH mount and a culture and a PCR. So we had almost 20 samples under the study, out of which KOH showed a septate hyphae. That is very typical of mucormycosis in 12 samples. There were 3 samples in which there was a mixed growth. It's like you can see 2 kinds of fungi in it. And there is 1 sample in which you can actually see aspergillus, clear aspergillus in the sample. And there are 4 samples which we could not detect any fungi. When you do a culture, out of the 12, only 8 could grow a mucor culture, right? And PCR, all 12 of them were PCR positive. So PCR is eventually turning out to be a very good confirmatory test, because KOH will anytime remain as a screening test. When it comes to a very young individual to take a call on major surgical debridement, that is where PCRs also play a big role. Now, the cases which were mixed, say you have aspergillus or you are not very clear on KOH what it is, we had 2 cases, out of which 1 was clearly negative for mucor PCR, and later on the culture it grew aspergillus. And there are 4 cases which KOH now found were negative, out of which 1 came PCR positive. So just to sum it up, I would request everyone to just open up the whole thing diagnosis to a lot more tests than just going in for a KOH mount for mucormycosis. At least put in a culture and a drug sensitivity testing so that the drugs that are used can be really used very efficiently. Now, this was a very small introduction or a glimpse into that beautiful world of microbiology. It's always nice. Thank you once again, Dr. Bhumkar, to give me such an opportunity. I would be open for any questions if there are any.
Thank you to the beautiful world of microbiology from the beautiful microbiologist. Brilliant. Just one question. Are you saying 3 days before, if we take a blood sample, we'll be able to anticipate a mucor infection? Is that what you said?
Yes. It is being very well documented in hematological malignancies.
In your lab, can we do this test?
Yes, we can do it here. So what we have is we have the whole facility of mycology right from your cultures to MALDI-TOF to PCRs to gene sequencing. So our kind of laboratories can actually do these testing.
Are there your kind of laboratories anywhere else in the country, or you're the only one?
Right now, no. There are a lot of studies which are being going on at PGI Chandigarh. So maybe they would shortly come up with such things. Yeah.
Thank you, Sonal. Thank you.
Sonal, what is the incidence of false negative with the blood?
False negative incidence is not being noted down. The sensitivity is given as high as 97%. Mm-hmm. So very rare chances that it will come negative.
So we probably need to bring this in the protocol for mucor now in the high risk cases.
Yes.
Yes. I need you to meet Dr. Oak and the task force. Yeah. If you don't mind, I think let's have Matthew make a comment, and then Matthew, if there's something you want to talk, and combined we could take the questions, because I'm not sure what he would like to say.
Yes, Dr. Matthew.
Can you unmute Matthew, please?
Sure. First of all, I'd like to thank you and the rest of the organizing committee for being here this morning or this afternoon in India's time. This is a real honor. Mucormycosis is a problem that you are fighting, that also the rest of the world has had to deal with as this pandemic rages on. And so to be a part of this unique group.
Do you have a mucor case in Canada?
Yes. So we absolutely have. I actually saw a patient last week with raging mucormycosis of the leg, in fact. This is not something that's unique to India. I do believe that the steroid situation, as you mentioned earlier, makes it worse. And probably the reason the rest of the world didn't see it during the first wave is that by then we didn't know we had to use dexamethasone, right? The recovery trial results were only published in July, whereas the first waves of the world were really in the spring. And so we didn't face the same steroid pressure. We didn't have the same opportunistic infections, including invasive fungal diseases such as Mucorales species. But we are seeing cases now. It's really quite dramatic, and this is something that we have to be aware of.
Do you have any presentation? Are you going to make?
Sure. I mean, I have. I wasn't sure what the.
Sorry, I think there was a communication.
No. I have a brief talk on.
If you listen to Sonal, is India up there where mucor is concerned? Is there something?
Absolutely. I think anywhere where Sonal is, it's going to be at the tip top of the list. What I would say is I think the diagnostic considerations are true there, like they are anywhere else in the world. It's a very challenging fungus to
is there anything different that you're doing than what she has proposed? Because currently we're just taking that crust and sending it over. But even for us, it was a new thing to know that there's a. Do you think the blood test could anticipate a mucor?
Yes, I think there's a fair bit of data to support that. The one research tool that some of us are developing are breath volatile. So you breathe into a tube and you measure the organic compounds that are associated with Mucorales, which is non-invasive. But otherwise, all the standard diagnostic testing is exactly what has been described before. And it is a very challenging bug to grow. And culture to identify the species is critical because we need to understand which antifungal is best suited for it. So I couldn't have presented it better myself.
Thank you, Matthews. Thank you. Sonal, that's a big compliment coming from the director of one of the most premier institutes on mycology. So Matthew, we'll keep reaching out to you in this mucor epidemic that we are facing. And all of us in India, we look forward to any help that we can get in terms of the knowledge, in terms of the tips. Like this was a very big thing, and I think we will most definitely take it up and try to bring it into a protocol. Because
right.
as you know,
the one thing I'd say is you have a lot of amphotericin, I understand, posaconazole. We have had very good success with isavuconazole, which is available in Canada, in the United States, in North America, many parts of Europe. I don't know if India has access to it. That is a very useful drug. It has many advantages. It shortens your QT for your cardiac patients. It has very stable drug levels, so you don't need to measure. It is active against a broad range of fungi, as is posaconazole. And if you are able to have that as part of your armamentarium, I think that would be very helpful.
We do have isavuconazole with us, but the question here is that there were some studies that says that it still is not the first drug of choice vis-a-vis liposomal amphobi. So what is your experience with the sensitivity profile between these two drugs?
Right. So the trial, that first showed that isavuconazole was effective was the VITAL study that was done by Francisco Marti at Harvard. He's my mentor, the late great Francisco Marti. And he himself, even though he brought the drug to market, he would agree with you, and he would say that isavuconazole is not the first-line treatment because there's a slightly higher risk of clinical failure when compared to amphotericin B. Now, that said, there are patients who cannot tolerate amphotericin B for long periods of time, or if there's a drug shortage. And so what we classically do is we almost start universally with amphotericin B while awaiting species identification and susceptibility testing. And then if we find that it's susceptible to isavuconazole, or if the patient has adverse events to amphotericin, then we will switch over to isavuconazole.
In your experience, do you have any have you seen any synergistic effects with echinocandins like caspofungin along with itraconazole? I mean, along with amphobi?
So this was part of the talk that I was going to show. Basically, there was a single study that came out of UCSF in San Francisco, in the United States, that showed that echinocandins in combination with amphotericin B were potentially better for rhinocerebral mucor. However, this was a non-randomized study, it was a retrospective cohort, and the data supporting this are really quite poor, which is the reason why in the 2019 Mucorales global guidelines that were spearheaded by Oliver Cornelli, they recommend monotherapy with amphotericin. And if there's a concern for critical disease, they recommend pushing the dose, normally given up to 5 milligrams per kilo, but in critical cases going all the way up to 10 milligrams per kilo.
Thank you.
Sonal, you have any question for Matthew?
No, I have a suggestion. I think there is a question which had come from you, saying that during the surgery, if you want to choose whether this tissue is actually a part of invasion or no. So the solution could be a fresh frozen section, like you take for any onco surgeries, that you take a fresh frozen section and process it for a PCR. So it would actually tell you whether this tissue is having mucor or no. That could be one suggestion.
We could send fresh frozen to you for the PCR?
Yes.
And in how much time could you tell us? 45 seconds?
3 hours. Takes 3 hours. Yeah. That's a little difficult, but then.
What is this 45 second thing? Can you tell us? What?
45 seconds, yes. That's a new technology called as MALDI-TOF. Not new in India. Yeah, so what you do is once the culture is up, a culture usually takes 24 to 48 hours. So we pick up the filaments from the mucor and we would mix it with the matrix. So what happens is this matrix ionizes the proteins which are present in the mucor, and then it is run through a vacuum. According to the molecular weight, these proteins will get dissociated, and you read those patterns with the existing library, and you actually can make out exact species which is present. The system which we use is Mucormycosis. So they have a very good filamentous fungi database. That's it.
So you recommend we do this for as many cases as possible.
Yes,
then you
yes.
can the drug.
Because then we will have a real good Indian studies coming up regarding to mucormycosis, because till now never the cases were so high that a big randomized control trial could be done on a mucormycosis. So if everyone starts sending samples just for a culture and sensitivity, I think we will have a big study coming out of these cases.
Lovely. Thank you so much.
Thank you.
Thank you.
Thank you very much. Matthew, we're going to reach out to you and maybe a small group with you and Sonal and some ENT friends and some other people from the government. We'll sort of talk to you all probably in next 2 or 3 days. I'll reach out to you and we will hook up and do something. Thank you so much. Is Satish there or he's gone? He's probably in the theater. Satish, are you there?
Another case.
Yeah, he is too prolific a surgeon. He's probably has to finish more cases. So I think it's Ashim, we can conclude.
Yes.
Thank you, Raj, Sonal, and thank you, Matthews, and thank you everybody. I don't know if Samir is there. Whoever we've invited as the guest of is Oksar there. I think there's something going on at the government level because that message came from the CM about the epidemic Mucor being included in the epidemic thing. So I hope and trust this was good for the Mucor warriors, the surgical, the MRI especially. And also I think now we need to look at the microbiology diagnosis very well. She brought up the point of the medical legal. Fortunately, we are not likely to be in that zone. Dr. Sonali Pandit has developed a wonderful consent form for Mucor, and I think it will soon get viral. It is so nice that it will soon get viral and it will become a part of this. That's more on the medical legal. But to be medically very judicious and accurate, I think we need to get down to what Sonal and Matthews has recommended. Microbiologically, not just have Mucor as a broad heading. And she's right because the steroid or whatever we believe, it's not selectively going to favor a Mucor. It's going to be a whole range of fungal infections which are opportunistic, who are going to find this change in biochemistry very, very favorable. So probably there is something lurking. In the heart of my hearts, the fear is the virus came in the form of COVID, or the fungus has come in the form of Mucor. How far is the bacteria going to be? As ENTs, I'm scared about a tremendous rise in malignant otitis externa.
We have been seeing that. Have you noticed that? And my question is out to the Mucor warriors.
Of existing infections of cholesteatomas. Like in the first wave, we saw them actually destroying the labyrinth. And there is something which we could not for short of time have Sonal, but into crystal ball gazing about how to anticipate the future infections that are likely to come. And we hope they don't come. But that's something which Sonal is going to be doing at a research level. Now that we know that so many things can go wrong in this COVID, and once a person is infected with COVID, it does not end at 14 days, not even 3 months. I mean, the after effects are going to be long and for many months, I guess.
I think another thought for the future would be restoration of immunity with selective T cell and B cell activation and things like that. That would be a thought for the future also.
Yeah.
So we have to look at that. So thank you very much, everybody, for being with us. And
thank you, Raj. Thank you for everything.
Thank you, Raj. Thank you for your inputs and thank you for being there. And it was a pleasure interacting with all of you. And all the best to everybody.
Thank you.
Stay safe.
Thank you.
We can. Thank you, Sonal.
Wonderful.
Thanks. Bye-bye.
Bye.
We can leave.
Yep.
The cost will be what she wrote? The cost will be inclusive with fungal cultures, 2,000 rupees. Okay, leave.